Dr. I actually, he does not really need any introduction, but I will. Yeah. So maybe it's time to start, and I would
just
like
one
to
question
welcome
for the delegates. If you have any question answer session, you need to put in QA box, not in chat box. All the questions related to Dr. Simon talk, you need to put it in QA box. Any question Dr. Simon want to ask to the delegate, and you need to reply in the chat box. This is kindly make sure about it. Thank you. Yes, Dr. Ali.
Yeah, thanks. So first of all, I would like to welcome all the delegates that are participating to this long marathonic course. Okay, an extremely rich program which will cover a very wide range of what an examiner, a sonologist, a sonographer in obstetrics and gynecology would face in clinical practice. We have a long list of distinguished speakers. Myself, my name is Ali Youssef. I'm a consultant of obstetrics and gynecology in the University of Bologna in Italy. And I would not really want to make you lose any precious time. So I would introduce the first speaker, which really does not need any introduction, Professor Simon Meagher from Melbourne, Australia. He's an associate professor in the Department of Obstetrics and Gynaecology, University of Melbourne. He is a medical director of Monash Ultrasound for Women Center, and a long list of titles. He's the ambassador of the International Society of Ultrasound of Obstetrics and Gynaecology in Asia and the Pacific region. And a member of a long list of committees in the ISWOG, and above all, he's really an exceptional lecturer. I really enjoy his extremely illustrated and informative lectures, and actually, I think is one of the best person that you would give lectures in our field. So I'll just give the microphone to Simon, and I hope that you find the course informative and useful. So the microphone is for you, Simon.
Thanks very much, Ali, for that very kind introduction. And thank you, Yassine, for hosting the event and for the invitation to present here today. It's my second time presenting here, and it's a pleasure or a privilege to be invited by anyone at any point in time around the globe to present. And I am grateful for that privilege. And with respect to presenting in Dubai, and I know many parts of the globe, and I understand that you're all at different levels of training, and I will try and cover the broad spectrum to the essentials in what we need to know across the first trimester, fetal gastrointestinal tract abnormalities and fetal cardiac anomalies. And I'll go from basics and to beyond. And we will start the first talk, which for today is first trimester, which each talk I think I have 40 minutes. So I might just start my watch to go and start with first trimester fetal malformation. Now, in the subject of first trimester fetal malformation, I would have to say that probably around the globe, what most people do in the first trimester, they see it as an opportunity for dating pregnancy, establishing viability and setting a twins chorionicity. But in recent years, significant momentum has developed with regard to the detection of fetal malformation in the first trimester of pregnancy. And I think it's that I really want to cover, because I am one of those people who believe that, in fact, the majority of major fetal malformations can be identified in the first trimester of pregnancy. And really what I want you to walk away with is a belief that it is possible, and a protocol which I will share with you, that if you bring with you to work tomorrow morning and you have a systematic approach using this protocol, that you will arrive at a point in time where you believe and you are capable of identifying a major malformation in the first trimester of pregnancy. So my talk is divided into the following sections: an introduction. It's important we cover the ISUOG guidelines. I will talk about what you should measure in the first semester. At the center of the talk is malformation across all organ systems. It'll be important that I finish up with the importance of the protocol and what our protocol is and how that compares with the ISUOG protocol. And then maybe a glimpse to what lies ahead in the first semester in the future, because it is a shifting algorithm of screening for both structural malformation and for aneuploidy with the
Dr. Simon,
yes?
Did you share your presentation? You didn't share the
Oh,
presentation.
you haven't got the presentation. Okay, sorry.
Yeah.
That's okay. But I think the algorithms have changed with the advent of NIPT, and I think while this talk will be hopefully up to date today, in the next few months, things will change. In the next couple of years, things are going to change dramatically with the advent of NIPT. And in fact, there are two ways it can go. It can either screening for malformation can die a death, and we do NIPT and an anatomy scan at 18 to 20 weeks, or NIPT is alive and well. We recognize the screening test, but screening for anatomical malformation gathers increased strength, because with NIPT, we have to do a scan before drawing blood for NIPT, and we precisely date the pregnancy. So we no longer do an anatomy scan at 11 to 14 weeks in our unit. We talk about the anatomy scan at 12 to 13 weeks of gestation. So these are the reasons that you would do a scan wherever you are across the globe. Is one, to gestational age, viability, and chorionicity. The second reason you do a first semester scan is to check nuchal translucency and combine that with biochemistry and risk calculate and then offer genetic testing. And then after that, the anatomy, and more recently, we have added in the last 5 years or so, maybe a bit longer than that, preeclampsia screening, and gathering increasing momentum is for other complications in pregnancy. So if you ask me, say, Simon, what is the ISUOG guidelines for first semester? The first thing I'll say to you is, well, it's very soon going to be updated. But let me tell you what it is as of 2013 guideline. Everything you see in red in that guideline is what's mandatory. And I will cover these with video clip demonstrations of all the mandatory. What I will add is what was optional in 2013, many of these will become mandatory in the next guideline. Most importantly is when we look at the heart in the first semester, I think it will become a standard that we look at the 4-chamber view of heart and looking at the 3-vessel tracheal view for outflow tract anomalies in the first semester, because now we recognize we can identify the majority of major malformation. So if we, what's happened to that slide? Something's disappeared on me. So if we look at the evidence for structural identification of structural malformation in the first semester of pregnancy, there are 19 studies in low risk populations which show that we can identify 46%. But if we look in high risk populations, we can identify 67% of major malformation in the first semester of pregnancy. And I would ask, well, why should it be any different between a high risk versus a low risk population? If you stick with the same protocol, no matter whether the patient is low risk or high risk, we should be achieving detection rates of 67%. And I'm pretty confident that that's the way things will go in the future. So if a patient walks into me tomorrow morning and says, Dr. Simon, how good do you think your scan is and what will it detect at 11 to 14 weeks of gestation? And I'll say, well, there will be a series of anomalies which are serious malformation, some of these lethal, which we would expect always to identify. There'll be a group which we will sometimes identify, and then there will be a group which we will never identify. Although within these individual groups, some of these sometimes, and were previously described as not detectable or less than 10%, will shift from one group to the other as we improve in our recognition of sonographic sequences of malformation and as the technology improves. Now I've got a problem with my presentation here and I'm going to have to reopen it. So I'm sorry, just let me shut that down, go into the drive and just let me reopen. it's just disengage the media. So let's give me 1 second. We should get this back running. Okay. I'm not sure how that red line has appeared in the middle of my screen. Okay, I'll continue with this presentation, and while we do question time, I might see if I can fix that, but I don't think it's going to interfere too much with things. Okay, so here's you going to work tomorrow morning. Can you still hear me?
Yes, yes, we can hear you.
Okay. So you're going to work tomorrow morning. The first thing you will do at 11 to 14 weeks is you will take a crown rump length and you will measure a nuchal translucency. You are all familiar with the landmarks for measuring a nuchal translucency. It needs to occupy 2/3 of the screen. Your lines need to be perpendicular to the transducer. And you see a little bit of fluid underneath the chest, so a fetus needs to be in a neutral position. And you need to have clearly defined points in measuring your nuchal translucency. And you will do that routinely at 11 to 14 weeks of gestation. But I think moving beyond that, I think there's good reason to measure a lot more than a crown rump length. I think we should also measure BPD, a head circumference. And when I talk about brain malformation, I will mention the importance of that. And then the abdominal circumference and femur length. And it's important to be aware that both the BPD and crown rump length are currently, is what recommended in the guidelines in the first trimester of pregnancy. With regard to the nuchal translucency measurement, looking at this, if you want to improve your precision of assessing the nuchal translucency, you can take a 3D volume. Now I will just add this because it crops up in all my talks, is that the power of 3D, everybody thinks of rendered images of fetal faces and so on, but I don't see that as being the power of 3D. The greatest power of 3D is volume contrast imaging. So when you sweep across this fetus and take a nuchal translucency, for me, this image is much sharper than this image. The definition of the nuchal translucency, the definition of the cerebral fourth ventricle, the definition of the brainstem, the definition of the cerebral peduncles, the definition of the thalmi is all much clearer than anything that you get in 2D. In fact, if you look at any single paper that's ever been published in the White Journal relating to structural malformation over the last 10 years in the White Journal, you will see they are all taken with 3D with volume contrast imaging. And all you do is simply hit the 3D button and take a sweep and press the button that says volume contrast imaging and select a slice thickness of 1 millimeter in the first trimester. And in doing so, you will get very crisp definition of anatomy. That's just a passing practical point. So what I want to do now is to walk you through the anatomical survey at 11 to 14 weeks of gestation. But as I said to you, in our unit, our model of care is that we do our pre and IPT at 10 weeks, and therefore we precisely date our pregnancy, and we call the anatomy scan the 12 to 13 week scan. So all these anatomical sequences that I'll be showing you are scans done at that precise time. The advantage of a scan at 13 weeks of gestation is when you look at the fetal head, is not only are you going to take a BPD and head circumference, but you can see other landmarks. The first most important landmark that you see is that the calvarium is ossified. Is ossifies at this point here at 10 weeks of gestation. So at 10 weeks, you should see the calvarium. As you go along through the occipital bone by 12 and 13 weeks, that is ossified. And as you go down through these sections, you recognize that the fluid here is the lateral ventricle, and this here is the choroid of the lateral ventricle. And then you can see in here a slight indentation of the sylvian fissure very early in the pregnancy. The next step as you move down is you see a ovoid fluid-filled space in the center between the two cerebral hemispheres, which is, I believe, to be the cavum velum interpositum, or the roof of the fourth ventricle. And when you then go down lower to the next level, you are at the midbrain. And all of you are familiar with the BPD. The only difference is at 13 weeks, there's no cavum septum pellucidum. But there is a box of fluid, which is called the aqueduct of Sylvius. And we routinely measure the posterior border of that to the inner border of the occiput. When you then move down from the aqueduct of Sylvius, you then see the fluid-filled space of the fourth ventricle. And that appears as a narrow, slender box of fluid. The importance of this is this fluid-filled space is called the intracranial translucency, but the advantage of looking at this in an axial section is much larger than measuring in a sagittal section where you see a fluid-filled space, just like a nuchal translucency. It's a big space when you look at it axially. And the advantage of recognizing the normal landmarks of this space covered by the echogenic tissue of the choroid becomes very important in brain malformation. So if you understand these 4 landmarks, what I actually encourage you to do is when you go to work tomorrow for your next 12 to 13 week scan, use an amniotic fluid index in your machine and use it to define the 4 segments of the brain. And in defining those 4 segments of the brain, it would allow you to pick up many brain malformations in the first trimester of pregnancy. 40 minutes doesn't allow me to go through all of those brain malformations, but briefly, the absence of the calvarium will allow you to detect acrania. If you get missing of the falx or sharing of the anterior ventricles, will give you holoprosencephaly. Absence of the third ventricle or this fluid-filled space, the cavum velum interpositum, is a feature of open spina bifida. Dilatation of the third ventricle with aqueduct stenosis. Dilatation of the lateral ventricles with aqueduct stenosis, which you can see in the first trimester of pregnancy. A diminution in the size or reduced BPD, a feature of holoprosencephaly and open spina bifida. A disappearance of the fluid of the aqueduct of Sylvius and open spina bifida. Disappearance of the fourth ventricle and open spina bifida, or enlargement of the fourth ventricle or dilated fourth ventricle, which is a very strong marker for digyneic triploidy or triploidy in general, but also trisomy 13 and trisomy 18, but not trisomy 21. It's also a marker of dilated fourth ventricle of posterior fossa anomalies. So that's just briefly an overview of why you would do those 4 sections to identify those major anomaly sequences. And most of those are identifiable in the vast majority, and in Kypros Nicolaides' study, to 100% of cases in the first trimester. So if you're a woman who's pregnant at 13 weeks of gestation, you're having a scan, for most, they want that diagnosis of a lethal abnormality in the first trimester, not the second trimester of pregnancy. So that's the axial assessment. The next, moving on to a sagittal assessment. Now, the sagittal assessment, there's an easy way of looking at this, because for those of you who are not familiar with all these lines and spaces, there is a learning curve. This is here, a fluid or an echogenic line here, an echogenic line here, an echogenic line here, an echogenic line here, and an echogenic line here. In between it, you have fluid-filled space of the brainstem, fluid-filled space of the fourth ventricle, fluid-filled space of the sternum magna, and fluid-filled space of the nuchal translucency. That's a lot of lines and spaces. I didn't say what these were. This is the anterior border of the brainstem, the posterior border of the brainstem. What I've done is taken these 3 spaces and drawn them over here. Is the larger being the brainstem, the next is the intracranial translucency or the cerebral fourth ventricle, and the next is the sternum magna. So all you have to do as a starting point for those of you who are junior in training, go to work tomorrow and look at these 3 spaces, and they should be in the order of size 3, 2, and 1. That's the first step. The next step after that is if you're going to measure anything, and you can measure lots of other things, but probably the most recent meta-analysis of the next strongest markers with regard to spina bifida and for posterior fossa anomalies for the ones I've just mentioned are a reduction between the posterior border of the brainstem to the inner border of the occiput. And that's called the brainstem to occipital bone distance. The other marker which you can take, which is equally powerful and it's got many other benefits, is just simply taking the intracranial translucency. That's an easier measurement because it's a more visible measurement. This is a more powerful measurement because it includes both an increase and decrease in the fourth ventricle, but it also incorporates the shift in the midbrain. So in summary, you measure 3, 2, and 1, or you choose brainstem, occipital bone, or intracranial translucency, or if you are a purist, you measure all 3. So in this case, there are simply no landmarks that resemble any of those. Here is a section through the head. You should be seeing the midline falx. You see a fourth ventricle. You're not seeing your choroid. You're not seeing the fluid around the choroid. You're not seeing a lateral ventricle. You're seeing an unrecognizable mass of tissue sitting up on the top of the head. And that is a fetus with a crania. So that's an unmistakable diagnosis on one condition, that you routinely take a BPD and head circumference in the first trimester of pregnancy. Because if you are somebody who just does a crown rump length, you may not recognize that this is an abnormal head. It may just be you taking a CRL and you're focused on that, and your focus is solely on the nuchal translucency and you're not thinking about anything else. Because if you do that, you might end up in an embarrassing situation where the patient was back at 20 weeks with acrania and she will ask, why wasn't this identified at the earlier scan? And I think if you do those 4 section analysis, or as a minimum, just look for your cerebral peduncles and recognize there's no CSP and take a measurement. When you do so, make sure that there are no choroids in view, in which case you're oblique. So you should have no choroids in view when you're taking your BPD. You'll have the striking box of fluid and your cerebral peduncles here and here. You're all familiar with a BPD assessment. But if you do that in head circumference, you will never miss acrania. I will skip through the others by showing them in 3D. So this is examples of acrania going from 12 weeks here to 10 weeks and to 8 weeks. So we're recognizing the more we screen is the more that we can identify these serious abnormalities very early in pregnancy. And this is just using, for speed of time, showing you the irregular appearance to the calvarium. And very early at 8 weeks of gestation, you get that bilobular appearance to the fetal brain at 8 weeks. With regard to encephaloceles, or the other abnormality which you can pick up this early stage, and it appears as a fluid-filled space with tissue herniating through the occiput. But with this, you will also get all the signs of spina bifida, a reduction in the intracranial translucency, disappearance of the cisterna magna, shift of the midbrain, a reduction in the distance between the aqueductus sylvius and the occipital bone. And then there's here the holoprosencephaly, which presents as a single anterior monoventricle, and the choroids have got a very abnormal appearance where they're shared across the midline to the choroids, and coming back to the ventricle, you see the ventricle is shared across as a single anterior monoventricle, and this is the anterior monoventricle. You can take a digital cast of that in the bottom right-hand corner where you see a single anterior monoventricle. Here's the third ventricle, and this is your striking aqueduct. You see the size of the aqueduct. It's really quite a significant structure early in the first semester of pregnancy. But the abnormal findings are the shared anterior monoventricle and the big dilated fourth ventricle, which I mentioned is a marker for trisomy 13, which you know is strongly associated with holoprosencephaly. So when I see something that looks like semilobar or lobar holoprosencephaly in the first semester, the first thing I do is I go looking at the fourth ventricle and ask myself, is it dilated? Let's move to the face. With regard to the issue of guidelines on assessment of the fetal face, there are 3 planes: the sagittal, the axial, and the coronal. For me, the most informative plane is the axial, and I'll talk about the 2 sections that we need to take when looking in the axial. The profile is an extremely informative plane, but it's not just for the face, it's for many other structures. It's for the hard palate, and it's for the brain structures: thalamus, peduncles, anterior border, posterior border, brainstem, fourth ventricle, and nuchal translucency. But for the profile, in terms of looking at a fetal profile, it's important to recognize these landmarks: the nasal bone, the frontal bone, the maxilla, and the mandible. So let's go through these 3 sections. So you go to work tomorrow morning, and now you've recognized these lines and spaces in the brain, but now you're focusing on the face. The one thing you do when you look at the face at 12 to 13 weeks of gestation, and I think it's a very useful exercise, is to just draw a line up from the mandible to the maxilla and just see that they're in line with each other. And the reason I suggest that is for two reasons. One is with the bilateral cleft, this maxillary bone is pushed forward. So if you draw a line, you'll find that this line is pushed out and the distance between the forehead and that line is increased. And in the setting of micronathia, the jaw is sitting back here. So if you draw a line up to the tip of the maxilla, similarly, a line from the frontal bone to intersecting that line is increased. But you don't really have to do that. In a sense, all you have to do is just look at these and see that the maxilla is in line with the mandible. And if you do that routinely, and you also look to see if there's a gap here in the maxilla, which is a feature of a facial cleft. But if you routinely look to see these are in line, you're looking for micronathia or the features of bilateral cleft. And in some, it may be so striking, the fact that there's no jaw. The second section. The second section is the coronal. Now, in the first semester, it's actually quite hard to see the lips. I've shown you a nice example using a linear 9 probe, which shows you the lower lip and the upper lip. And here's the philtrum. So you screen through that. What's far more important than the lips is seeing this band of bone, which is a triangle. And that's the retronasal triangle described by Waldo Sepulveda. And here's the base of the triangle. And that's what you're looking at, is the base of the triangle, because that's where the information is. And you're asking, is the bone interrupted, either through a unilateral or bilateral cleft? The one I like, which I feel is in a screening context of picking up abnormalities, which you then take to these sections, is the axial section. And I call it max and man. And what I do is I do a split screen and I draw here is the mandible, which has got a gap in it, mandibular gap, which is normal. If the gap is missing, it's a feature of hypoplasia of the mandible or retronathia. When you look at the mandible, the bone goes all the way back to the temporomandibular joint, and it's got quite an acute angle, whereas the maxilla has got a much wider angle and it's a much more shorter-lived bone for the sockets of the teeth buds. It's important when you're looking at the face to recognize these two landmarks, split the maxilla and the mandible. And when you get to doing that over the next 100 patients, you'll become very familiar of what the brain looks like and the face looks like in an axial section. You're seeing the mandibular gap, you're seeing the normal shape, you're referencing the shape to the shape of the maxilla, which is intact, and importantly, that the upper lip is intact and there's no facial clefting. So when you look at the face, there are many angles that are being described, which is well beyond the scope of this talk, but this is the one which I think is probably the most useful, is the prefrontal space distance. The frontomaxillary facial angle, which is increased in babies with Down syndrome, reduced in babies with spina bifida and holoprosencephaly. The prenasal space distance increases with babies with Down syndrome and fetal hydrops. The distance of the palatine maxillary bone, which is reduced in facial clefting. The premaxillary space distance, which is increased in babies with Down syndrome. I'm sorry, this was showing the nasal bone, this one, the length of the nasal bone. So there's two structures, the nasal bone and the prenasal space. And lastly, described by Katia Bellardo recently, drawing a line down from the nasium to the tip of the mandible and the tip of the maxilla and measuring this tiny angle to see if there's any change. So there are many things you can measure in the fetal face. I'm not a huge fan of measuring all of these in a routine screening context. I think if you're going to choose any, this is one which is probably the greatest yield in terms of micronathia, facial clefting, holoprosencephaly, and spina bifida. Next is moving on to the coronal section after doing the axial. As you do so, as you improve your image recognition abilities, you will see that you can identify facial clefting on a coronal section because there's a defect on the lip here and a defect on the lip here. But as you start looking at it, it's at the beginning, that's quite hard to appreciate that defect because they're so tiny. And that's why I say axial is more reliable. So you can see the gap here and the gap here. And you can also see that the gap goes through the maxilla on both sides. You drop down to the mandibular gap. And as you come up here to the maxilla, you can see the breach, but not only you can see the breach, but you can see the track of the bone going down the hard palate. So I just find it's a more reliable, and ideally you want this up at 12 o'clock. And the axial resolution on an axial section for me is probably the defined, is very useful in a screening context for facial clefts. But with improving resolution and frequency, we are now recognizing more and more by coronal imaging, less so in a screening context in sagittal imaging for facial clefts, unless it's bilateral, as is this case, where you draw a line up from the maxilla up to the from the mandible up to the maxilla, and you see the distance is so far away from the most protuberant part of the forehead. But, you know, eyeballing that, for me, I recognize that straight up that's, but you may not. And you say, well, the way to get to a position where you do recognize it is simply measured 100 times that prefrontal space distance. And when you get to know what it is, then you will recognize what an abnormal facial profile is. Remembering the prefrontal space distance can also be negative in a normal fetuses. And then there's soft tissue with rendering. You can use 3D rendering techniques. So this is showing a defect in the fetal lip, and this is in 14 weeks of gestation. And then this is using multiplanar. So this is going up a level in your imaging. And this is a fetus who's got a maxillary gap. So once you see that, it's a marker that the fetus has got a cleft. There's no premaxillary protrusion, so you've got no clue there. But when you look at your retronasal triangle, you've got clearly a defect in your retronasal triangle. Not only that, but the defect in the retronasal triangle corresponds exactly with the maxillary gap. So this is not a false positive. With maxillary gaps, you have to be careful because there's a significant false positive rate. That's the beauty of multiplanar analysis, is allows me to specifically reference that exact anatomical point. It's important because in this fetus, there was no facial cleft lip. The lips were intact. It was just an isolated defect in the palate. And as you sweep back to the lips, you will see that the lips here are intact. There's no cleft lip and no premaxillary protrusion. You can go down to finer detail in the first trimester, and look, here is the pharynx, the tongue, and you can see the uvula and the equal sign of the soft palate in a fetus at 13 weeks of gestation. But to be honest with you, I don't think anybody in the world is screening for soft palate, isolated soft palate defects, looking for the absence of the equal sign at 13 weeks of gestation. But who knows, that may change in the future. And then there's on to looking for facial dysmorphic faces. And this is a fetus with cupped ears and a dysmorphic face, where there's a single nostril, sebocephaly, in a fetus with holoprosencephaly. So it's a very enlarged, abnormal looking nose. And in this case, the other more sophisticated techniques are using the flip face view. And for some of you who are familiar with this, and this is using maximum mode, and you can track here the full defect in the fetus with a unilateral cleft lip, cleft palate. Here you can appreciate the mandibular gap, but really with maximum mode, I think it gives you much better definition of the full palatal thickness through the primary and secondary hard palate, which you simply cannot achieve with 2D imaging. And then there's this fetus comes in to see you tomorrow morning. You recognize the brainstem's normal, the intracranial translucency is normal, cisterna magna is normal, and so is the nuchal translucency. But you do recognize that you get a much crisper image when you go to 3D VCI. So this was 2D here, that was 2D, and then VCI seconds later. See how much clearer that is. And the advantage of volume contrast imaging, it enhances the borders between tissue structures of different density, and that's at the core of anatomical diagnosis. And that's why I see that as being a very powerful tool in the first trimester. The prefrontal face distance is completely off the chart because this fetus has got no chin. So this is anathia. And anytime you see anathia, the next step is to look at the fetal ears to see if the ears are approximated, a condition called autocephaly, which is a very rare and serious malformation. When you look at the retronasal triangle, you see it's actually intact. And that's important because if there's anathia, the first thing I think of is after the ears is to see whether there's an associated hard palate defect. There are a separate group of patients, this is at 12 weeks of 4 days, who I see in a first trimester scan. And when I see something like this, I ask myself, is this micronathia? Well, the first thing is I'll draw a line up from the tip of the mandible up to the tip of the maxilla. Oh, my hand's a bit shaky, but I see that the prefrontal, let me try and do that again. I see the prefrontal space distance is increased. So that distance is increased. But if you eyeball it, you can see that this looks like this fetus has got retronathia. So that's, for most, that will be micronathia. Now I've got to make a call in this patient. She's sitting on the couch, everything else in the scan's normal. Am I going to call this as being an abnormal profile? Well, the first thing I'll ask is, has she had prior NIPT? Because I want to know, is there any evidence of 13 or 18? If the rest of the scan is completely normal, I will cancel this patient very favorably, because many of these with the borderline micronathia are transient and are resolved by 17 to 18 weeks. So I don't jump in with a chorion biopsy for mild micronathia in the first semester of pregnancy, because I recognize that that is a transient finding and many of these will return to normal. And this is using the 2 lines to measure your prefrontal space distance. Next is on to the neck. So when we look at the neck in the first semester of pregnancy, of course, the nuchal translucency is the most important, and I've already covered that. But the next most common abnormality you will see is a cystic hygroma. And for many of these, it's associated with Turner syndrome. So in the setting, and of course, Noonan syndrome, in the setting where it's a euploid fetus, it's important to look if there is any other associated malformation, because many of these, up to half of them, have associated malformation. So if you do the chorion biopsy, it comes back normal chromosomes, you have to go looking to see what is the associated abnormality with this cystic hygroma. Don't pass it off and wait for it to disappear as being nothing to be concerned about. But there's something far more common than that, and that's seeing dilated sacs in the fetal neck at 13 weeks of gestation, both here. These ones are quite striking. I think this one here in the bottom left-hand corner is more subtle. And these are a very common finding in the first semester of pregnancy. If everything else is normal and the nuchal translucency is thin and there's no markers of trisomy 21, I do not discuss or mention, I do not raise these with my patient. I recognize them as normal variants. It just creates too much anxiety. They are of no clinical significance, and this is a reference in the White Journal back to 2009 with regard to jugular lymphatic sacs in the first semester. I'm not saying completely ignore them. I am saying make sure there's no markers that support that there's aneuploidy, and once you've done that, then not to raise that with the patient, because there's no evidence that is associated with adverse outcome. Then there's the spine. In the spine assessing, the issue or guideline is to look at the normal vertebral alignment, the integrity, and the overlying skin. And the main reasons for this is to look for spina bifida. So if we look across here, we see a fluid-filled space at the base of the spine. If you look at it, depending on which series you wish to quote, but somewhere between the order of 30 to 50% of all open neural tube defects, open spina bifida, at 11 to 14 weeks may be identified by directly looking at the spine. That's a figure that's terribly overlooked in discussion and lecturing about spina bifida. We all talk about the head signs, but just remember that you can identify up to half of spina bifida with modern technology by looking at the spine. So don't forget that. It's so important to look at the lumbar sacral spine. And then once you've done so, you may improve your image of this by using 3D with VCI. You can see the cystic space here. And then you can take the rendered image, which shows the lumbar sacral region. For spina bifida, approximately 80 to 85% of them occur in this lumbar sacral region. What's most challenging is the 5 to 10% that will be myeloceles, which are extremely challenging group. They don't present as a bleb, but you've got a skin line that looks as though it's continuous all the way down. But in fact, there's a tiny little ulcer in the skin. And these are not recognized by looking directly at the spine, but rather at the head. And it's identifying that tiny little ulcer that can be so difficult in the first semester of pregnancy. And then there's hemivertebrae. Hemivertebrae, for many of these that we pick up in the first semester, they're related to something else. So we find that there's a cardiac abnormality or features suggestive of VATRL or VATR that makes us look at the spine. But on occasion, as in this fetus, we'll pick them up as being isolated. In the bottom left-hand corner, this was isolated. So I wanted to show you, first of all, a normal spine. When you're looking at the spine, you look at the spine's processes. This is any spine at any gestation. You separate it into 2 parts. You look at the spinous processes to see that there are a string of beads, equidistant and of normal size. The next part you look at is the transverse processes. You must treat these separately in routine imaging. And when imaging the spine, when I go to work every day, I do it as a 4-quadrant So I select a 4-quadrant box and I demonstrate the beads starting off at the sacrum, working up to the lumbar spine, lumbar to the thoracic, then the thoracic, and then the thoracocervical. And then I do a separate box for the transverse processes. And that, from a medical legal point of view, will protect you that you directly image all 4 segments as you move up from top to tail, from cervical to sacral spine. It's just a personal thing I do in imaging. There's nothing in print to recommend that. From the point of view of looking at the spine in 3D, you acquire a volume. And the advantage of that is it allows you to display the entire length of the spine, either by using OmniView, or if the fetus is in a good position, multiplanar. And this is the exact same on a fetus that was completely normal, acquiring a volume, crossing the fetus, sweeping from left to right. Mother holds her breath, you acquire sitting with maximum quality. You place your reference dot over the skin. And once you've placed your reference dot over the skin, which you're bringing it to this point now, then you rotate on the y-axis. And as you do so, you've now got the skin you translate through to get the vertebral bodies. And as you translate to get the vertebral bodies, you turn down your contrast and gain, and then you've highlighted your tilt in your spine and your hemi or absent vertebrae. So that's achievable in the first trimester of pregnancy. In the interest of time, I just might skip that. And then we'll go to the thorax. With regard to examination of the thorax in the first trimester of pregnancy, I think it's probably less yield than it is of the second trimester, simply because we cannot identify congenital pulmonary airway malformation. Both sequestration and CCAM are not visible in the first trimester of pregnancy and have not been reported to date. In contrast, though, we can pick up diaphragmatic hernia, a small proportion, and I'll walk you through those because they're an important group. And then there's the group of hydrothorax. If you ever see hydrothorax, you need to think of cardiac exstrophy, particularly for the large and bilateral hydrothoraces. So in this instance, in the fetus where you scan and you see striking large bilateral hydrothoraces, this is very early in pregnancy. In a 9-week embryo, you then need to focus your attention on the heart. And this is here showing the heart pulsating outside the fetal chest. But this is a very rare abnormality. In contrast, diaphragmatic hernia is a much more common abnormality. And what you might see in the first trimester are 2 things. One, you see a bubble sitting beside the 4-chamber view of heart. And the second thing you know is the heart is shifted from the left chest into the right chest. They're the 2 criteria which you rely on in seeing a left-sided diaphragmatic hernia in the second trimester of pregnancy. But for me, I don't really like that image because I'm losing detail because I'm firing at a far too low a frequency. So I take out a probe and I use a higher frequency. I take the exact same patient and now I move to 9 megahertz. I can see the definition of the 4 chambers. I can see the inflow into the ventricles. I can see the stomach bubble, and I can see the 3-vessel tracheal view of the cardiac outflow tracts. I was getting none of that detail firing at a megahertz, starting at 2 megahertz to 9. So it's important in the first trimester to maximize imaging by using high frequency where possible. For us personally, we use endovaginal high frequency probes. And then there's the group with the pleural effusions, small pleural effusions. Anytime you see that, you need to be suspicious of Turner's and Down's syndrome, but be cautious because at 10 weeks of gestation, a small amount of fluid in the pleural spaces is a common and normal variant. And then this is a fetus with bilateral pleural effusions, but you will also note that it's got subcutaneous edema. So when you see that, that's a far more sinister finding, seeing pleural effusion the first trimester in that setting. And then there's on to the heart. So when you look onto the heart, in the ISUO guidelines, it suggests not to use color. And I think for that reason, I say is the current guidelines is out of date, because I think it's recognized across the globe that we really should be routinely using color in the first trimester of pregnancy. It's a very powerful tool, and the updated guideline will reflect that. And what we need to look at is the 4-chamber and the 3-vessel tracheal view, because you know, as the cardiac guidelines, which we'll discuss shortly, recommends 5 sectionals. The first trimester, I think you'll need to do 2, the 4-chamber and the 3-vessel tracheal view. You need to have your fingers on a number of controls. You need to have, firstly, on the control of color and power. So you need to mostly reduce your output because it's too great for many when you turn on for first trimester. And you need to set your PRF. But the first thing you set, I got the order wrong for that, is your PRF you set first. And you set that at 20 centimeters a second to 25 centimeters a second for a 12 to 30 minute scan. 2, you'll find for many machines that when you set that setting, you need to, it's too much, then you turn down your color gain. Don't turn your PRF up, turn down your color gain. So your preset has to reference what is the expected velocity for the gestation you're at. So 25 to 35 is fine. And then if that's still too much color, then turn down your power. And that's the order I would do routinely in imaging a heart in the first trimester of pregnancy. So here we go, 23 centimeters a second, and I'm demonstrating that there's a normal inflow, and then I'm demonstrating that there's normal 3-vessel tracheal view. And that's achievable in first trimester imaging, very achievable. And what I encourage you to do is demonstrate the 4-chamber and the 3-vessel as a split pane image. You may find that hard to do at the beginning, but once you've done it 100 times, you will have mastered looking at the normal heart, and you will recognize all the anomalies, or many of the anomaly sequences. If you want to go a step further, take out the linear 9, and you can make a first trimester heart look like a second trimester heart. But this is a 13-week gestation heart showing the inflow and the 3-vessel tracheal view in the same detail that you would see in the second trimester. And I split the image showing as a 4-chamber inflow being in red and the 3-vessel tracheal view as being in blue. That gives me immense peace of mind that this heart is normal. So you ask me then, Simon, what abnormalities can you pick up in the first trimester? And I would say to you, well, the better question to ask is what abnormalities can you not pick up when you look at that list? And I think probably the best way to look at it is the anomalies which you are basically don't develop in the first trimester: tumors, cardiomyopathies, heart black, and pulmonary valve stenosis. And then simply those that are too tiny or too difficult to recognize, which are difficult at every stage of gestation: perimembranous VSDs, anomalous pulmonary venous return, and partial AV canal defects. So in essence, I'm saying is the majority of common major malformations can be identified. And I think if we look how we've improved over the years, our detection rates have got better and better. And now here we are in 2021 with a paper that's fresh, saying that 80% of cardiac defects can be identified in the first trimester of pregnancy. And I absolutely believe that. And I believe it because if you look at a 4-chamber and a 3-vessel tracheal view, you can identify cardiac malformation. And these, just to give you examples, are examples of cardiac abnormalities at 12 weeks, which is an aberrant right subclavian artery, and a fetus with a absent ductus venosus draining directly here in the cord insertion and coming down and inserting into the IVC. It should be inserting in here and joining the right hepatic vein and the IVC and entering into the right atrium. Here at 13 weeks of gestation is a fetus with a right aortic arch, that typical U configuration, and in the center is the trachea, which you can see at 13 weeks of gestation. A common abnormality in the first trimester is an absent or visible left ventricle. This is a hypoplastic left heart, and then here is the main pulmonary artery, which is dilated, and then the reversal of flow, exactly the same what you would see at 18 to 20 weeks of gestation. And in this features a common arterial trunk, which is the trunk here giving off the pulmonary artery and continuing on as the aorta in a fetus at 13 weeks of gestation. It happens to be coming out of the right ventricle, and of common arterial trunks, 40% come out of the right ventricle. The other 60% are central, coming out of the fetal chest. So for cardiac abnormality, I'll be covering anomaly sequences in my heart talk, but all the anomalies I'll be talking about I will be making reference to how you can identify these in the first trimester. For the abdomen and the abdominal wall, I'll be covering in my next talk in the on the abdomen. So I'll jump to limbs and genitalia and finish up the first trimester. We routinely look at the arms, legs, hands, and feet in the first trimester of pregnancy. Again, I encourage split imaging when looking at right and left side. 2, I encourage turning up your dynamic range, and I encourage doing that for looking at the bones at any stage in gestation. And this is using a linear 9 in a fetus at 12 weeks and 4 days of gestation. And you can readily identify the fingers and digits of the hand. If you want, you can move to a higher plane of imaging and look with 3D render. And this is a 13-week fetus looking at a rendered image of a fetal hand, but I would not do that in routine imaging. The fetal feet are much harder to image. When I say that, to count digits is much harder in the feet when compared to the hands in the first trimester. So what I'm looking for are two things. One, I'm looking to see if the foot comes off at a correct angle to the leg. Be careful you don't use this foot relating to this leg and you'll end up calling talipes. That's something you can do at any stage during pregnancy. It's a trap for young players. Make sure that this foot that relates to this leg, and confirm that you've got both your fib and your tib. So that's the first thing I'm looking at, is the ankles. The second thing I'm looking at is the digits. And I've chosen a nice example of a fetus at 13 weeks of gestation, but this is not real life. You don't see digits this easily in a routine scan when you go into work tomorrow morning. But I look at the shape of the foot. And when I see a foot that's broadened, well, that's a feature for me of polydactyly. So you may not be able to see it. The broadening actually doesn't occur on that side. The broadening is on the opposite side because most polydactylies are post-axial, not pre-axial. And then you can move on to using 3D render. And that's actually quite easy to do in the first trimester of pregnancy. But again, that's not something that we would routinely do in imaging at 13 to 14 weeks of gestation. And then for the anomalies, I will just show a static image of these: polydactyly, ectrodactyly, oligodactyly, that's 4 fingers, and this is olidactyly of 3 fingers. And then important to distinguish between these two, because that's oligodactyly with 3. This is oligosyndactyly. You've got 1 digit here, but these two are fused, which is far more sinister. And anytime I see oligosyndactyly of the hands, the next thing I go to is looking to see is there any evidence of facial clefting as part of ectrodactyly ectodermal syndrome. Of these digital abnormalities, 40% of them can be identified in the first trimester of pregnancy, and 75% of transverse limb defects can be identified, either a missing hand, a missing forearm, or an entirely missing full length of an arm, or missing in the top left-hand corner lower limbs. These are generally related to vascular events, transverse limb defects, but they are very identifiable in the first trimester of pregnancy. So in summary, when we look at the first trimester of pregnancy, we recognize that, you know, there are anomalies which you can sometimes see, anomalies which you can always see, and anomalies which you will never be able to see, and you need to recognize what the limitations are. I think probably the most important thing is what difference does this talk make to you tomorrow morning is I hope that it encourages you to have a protocol. And I think in having a protocol, if you go through the processes of looking at 4 sections of the head, looking at 3 spaces of descending aorta and measuring the intracranial translucency, dividing the face into the maxilla and the mandible, looking for the gap and looking for the intactness of the lip over the maxilla, moving to the limbs and splitting an image, confirming that you've got 1 hand and forearm bones on one side, and you don't end up counting the same hand twice. That's much easier to make that mistake at the second trimester. You're far more likely to pick up digital and transverse limb defects in the first than you are at any other stage during pregnancy. And then doing a split image, looking at a 4-chamber view of heart and outflow tracts as part of a routine scan at 12 to 13 weeks. And once you do that, you then move down to the lower torso. You identify the kidneys, 3-vessel cord, the intrahepatic vein, the spine, the legs, splitting the image, and finishing up by looking at the placenta. And I think if you established that routine approach in imaging at 12 to 13 weeks of gestation, you will arrive at a point where you have a protocol that looks like this. It's more detailed than the ISUA guidelines, but if you are a believer that you can identify the majority of major malformation 11 to 14 weeks of gestation, you will adopt this protocol, because the sonographic appearances of malformation at 12 to 13 weeks are no different to what they are at 18 to 20 weeks, with the exception the brain. For everything else, what you know and recognize the mid-trimester, it looks exactly the same at 12 to 13 weeks of gestation. And a word for the future in the first trimester. I think in the first trimester, we'll be moving earlier. I think we'll be seeing anomalies between late 6 weeks, 7 weeks of gestation to 10 weeks of gestation. And I think we're beginning to recognize that there are some anomalies that you can identify at the time of the NIPT scan. We draw blood at 10 weeks for NIPT. So at that stage, you can recognize anomaly sequences, and this may change the algorithm in how we screen and the timing of diagnostic test in the future. If you are a pessimist, you may turn around, you may say to me, Simon, I don't think there's reliable evidence for early anomaly detection. I'd say to you in 2021, I disagree with that. You say to me, I don't think the screening window is cost effective. And I would say, well, if the evidence is you can identify 2/3 of anomaly, I don't see why not. I think there are in development of organ system. With number 3, I would agree with you. Number 4, there is a decreased availability of skilled personnel to perform these examinations, and the work is much harder to get the diagnostic images. I don't think that's a reason. I think it's an impetus for change. If you recognize that you can achieve those images, I think that's the challenge to move to that next step. And I think probably the argument that I would put that's in number 7 should be in number 1. You have to be careful about false positive diagnosis leading to inadvertent TOP. Well, the comment I would make about that is the criteria which you use to make the diagnosis in the mid-trimester of pregnancy is exactly the same in the first trimester. You can have the same level of confidence, particularly with regard to the lethal malformations, say crania, holoprosencephaly, encephaloceles. It is no different. But for those which are more subtle, if you are ever in doubt, you need to opt for a second opinion. In a sense, in Australia, where I work, I don't need to make the case for 12 to 13 week scan, because this is what obstetricians want and it's what patients want. We recognize that we can provide a diagnosis for over the majority of major malformation. There are practical and psychological benefits to mothers knowing this information, whether they choose to continue their pregnancy or not. The advantage of early diagnosis for many, it allows early initiation of genetic testing, early introduction of a multidisciplinary approach, and allows a patient to settle in and adapt to what lies ahead for her pregnancy and make sure that all testing is complete. I don't think it's competing with the anatomy scan. I see them as different. I see that the first trimester scan predicts adverse pregnancy outcome markers for aneuploidy structural malformation. And I recognize that it will never identify all anomalies. I recognize that the 18 to 20 week scan is a complementary scan. It'll pick up the anomalies that are more subtle, that are not picked up at 12 to 13 weeks. So what we do is a 10-week pre and IPT, 12 to 13 week anatomy scan, and then an anatomy scan at 20 to 21 weeks of gestation. And that's the model of care in our unit and many other units worldwide. So I thank you for your attention. And I will just quickly go to the chat box to see if there's any questions from anybody. Chat box 4.
There's one question in QA box.
Yes. Okay. Just saying, all I can see is you're not visible to delegate. I can't see a. Can you read out the question to me? Oh, I've got it here. Cord insertion. Yes. Can I read the answer to the cord insertion? Well, I'll just show you very quickly let me lost my screen. My computer's playing up tonight. I'm not sure why. I can't see my PowerPoint and I can't see my screen. There we go. It's back. Not sure what it's doing. Okay, to go to the cord, let's do that. I'll make one very quick comment about the cord in the first trimester of pregnancy. The first is when you're looking at the cord, you need to look to see that the cord insertion site, you need to divide it into 2 parts. You have superiorly, you have the vein, superiorly, and inferiorly, you have both arteries. So if you look at the cord insertion, we take the spine here, and the cord comes in, the intrahepatic vein comes in and sweeps. You are looking at that superiorly, and then inferiorly, you are looking to see that the cord bifurcates either side of the fetal bladder. You will find in the first trimester that there's a thickness to the cord, and you need to treat these as 2 different levels, because in the first trimester, you're looking at the vein. That's where you will see the hernia. Physiological hernias occur in all fetuses around about 9 weeks of gestation, between 9 and 10 weeks and 5 days. It rotates 270 degrees, it returns to within the fetal abdomen. But you're going to identify that failed return of bowel by looking at the vein. The second comment is be very careful about making a false positive diagnosis of a 2-vessel umbilical cord because the arteries can come in at different levels. Thirdly, you can pick up that the arteries are different in sizes. There's a small artery when compared to a large artery, and this is tracking the same fetus later in pregnancy. The only real relevance to that is that when you're doing Doppler studies, you should never Doppler this vessel in the 3rd trimester. You should always Doppler the larger vessel. This will give you false positive readings if a fetus is at risk. And the first evidence that you may have of that is a scan at 13 weeks in gestation. You may, when you see it in the cord insertion of the abdominal wall, is then go directly and look at the cord. This is the smaller vessel here, and this is the larger artery here. And you can actually see these discordant arteries at 10 weeks of gestation. There's no evidence that they are associated with cardiac malformation in the published literature, but we anecdotally in our experiences, we treat a discordant umbilical artery no different to a single umbilical artery. So we just look extra close at the heart and check for fetal growth later in the pregnancy. So I hope that answers your question. Okay, good. I still have my screen. Yasreen, would you like me to reboot to get rid of this red mark, or is that red?
Yes,
Are you
yes, if you can. Yes, you take a couple of minutes. If
it
you
will
can
take a couple of minutes. I will be back to you shortly just to reboot and get rid of it.
Yeah.
I'll join you shortly.
In the meantime, we can give like a 5 minutes break. Is it okay? Doctor, just 5 minutes break, then we'll come. Then we'll start with the second lecture. In the meantime, if doctors have any question, you can put in a QA box. Then Dr. Simon will reply accordingly. Dr. Tracy, are you there? Is it fixed now?
I hope so. Let me just have a look. Have you got my screen?
Yeah, no.
Okay.
Just share your screen.
Let me know when you've got my screen. Have you got my screen?
Yeah, we got it.
Okay. All right, folks, so we'll keep going. I'll try and make up for lost time. So the next talk is gastrointestinal tract. So let me just...
There is one or two question, Dr. Simon, if you can take it.
Sure, no problem. And let me see if I go to Q&A.
Omphalocele.
Point out to say where am I? There's nothing in. I can't see
okay,
any.
you just join it. That's why.
Okay, so if you can read the question out.
Yeah, there is omphalocele. Omphalocele, sir.
Yes, I'm going to cover omphalocele in my next talk.
And one question, I think abdomen was not covered. Is it?
It's covered in my next talk.
Next talk. Okay, so then that's fine.
No problem. That's why I left them out.
Okay.
Okay, so the next talk is gastrointestinal tract malformation, and in the first semester for most of these, we are talking about anterior abdominal wall defects, of which there are many different types. And what I want to cover, which I've taken out of my talk on the first semester, is to discuss exactly that topic. So looking at this talk, it's divided into the following sections. I start with an introduction. From there, I move on to talking about omphalocele, then gastroschisis. And then there's a whole group of major malformations which we can identify for many of these as early as 8 weeks of gestation. I'm not encouraging or saying that that's what should become standard practice. It is standard practice, I think, that they should be identified at 12 to 13 weeks of gestation, but I just want to let you know what lies ahead in the future. And then I'll talk about fetal bowel obstruction in the first semester, and I'll finish up with comments about the protocol and with some summary and some comments. Okay, let's get my watch going. All right, so the first is looking at the ISIOR guidelines, and in the ISIOR guidelines, it pays specific attention to the following structures: the anterior abdominal wall, the stomach, the presence of the kidneys, and the cord insertion site, and the number of vessels in the cord. So there's quite a lot of detail provided in the ISIOR guidelines relating to the anterior abdominal wall and its contents. When you look at the anterior abdominal wall defects, if we divide them into these groups with schematics of omphalocele, gastroschisis, pentalogy of Cantrell, and then the OIES complex, which was historically known prior as cloacal dystrophy or extrophy, very serious abnormality, frequently associated with spinal defects. And then there's amniotic band, which has got a very varied presentation, but frequently involves the anterior abdominal wall and brain. And then there's body stalk anomaly, and sometimes in the past it was referred to as short cord. These are features with frequently have no visible umbilical cord with an omphalocele and typically have a scoliosis. So this is an image back from 2008, I think. So it's over 10 years old. And we've been diagnosing the first reported well before this of an anterior abdominal wall defect in the first semester of pregnancy, and they're striking. You can understand why the detection rate is the order of 100%, because we routinely look at the umbilical cord insertion, and in fact you can see them at this is a 10-week 4 days and then a 12-week fetus. So we can identify these very early in pregnancy because they are striking abnormalities, and we expect detection rates of 100%. An important abnormality because it is strongly associated with chromosome abnormalities, in particular trisomy 18. And if you look at it, about half of all of the omphaloceles. So if you think of one abnormality that's got the strongest association with chromosome abnormality, I would say I would pick omphalocele. And that's on traditional karyotype data. It may well change with genome-wide screening. About a fifth of them will present with an increased nuchal translucency. So you can't rely on the nuchal to help you pick it up because 4/5 of them will have a thin nuchal. And I was brought up and I was taught, when you see an omphalocele, Simon, if you see liver inside it, it's more likely to be chromosomally abnormal. But there's a good series of 95 cases in the first semester of pregnancy of omphalocele by Lacovela and colleagues, showing in fact there's no difference whether it contains bowel or liver. So in a scenario where I see a loop of bowel into the base of the cord at the level of the vein at 12, 13 weeks gestation, I routinely proceed to offering patients invasive genetic testing, typically by chorion biopsy, as frequently it's associated with other markers. The second comment to make relates to what do you say to a patient at 12, 13 weeks when you've found that there's an anterior abdominal wall defect? How do you counsel her? Well, first of all, you address the issue of chromosomes. You offer chorion biopsy, the fish comes back normal, and the chromosome microarray comes back but no abnormal findings. What are you going to say to the patient? Well, you look at the data from Tassin, again, a large series of first trimester omphaloceles, 79 cases before 14 weeks of gestation. What has been suggested is that you look, when you see the anterior abdominal wall, this here is your vertebral body, your transverse processes, here's your stomach, and you see your omphalocele herniating here. They contain typically bowel, and which is seen inferiorly, and liver, which is seen superiorly. and you appreciate superior inferior in a sagittal, not an axial section. So what you do is you prognosticate by taking the diameter of the omphalocele to the transabdominal diameter, and you use the ratio of A to the ratio of B. And if the omphalocele diameter is greater than transabdominal diameter, this suggests a poor prognosis. And looking at it, the second thing is neonatal morbidity. It's a useful predictor of neonatal mobility, difficulty, respiratory difficulty, feeding difficulties, and prolonged hospital stay. Then there's the contents of the hernia. You find that if the abdominal or the omphalocele circumference is greater than the abdominal, you can't work out what the contents are. It's more likely that it'll contain liver. I'm not sure that's that helpful. But what is helpful is this, is trying to predict whether this fetus is going to achieve a primary closure or a staged repair. And by measuring the circumference of the omphalocele, which I think is probably more helpful than measuring diameters. So you take the circumference of the omphalocele and your references to the circumference of the abdomen of A to the circumference B. And you can gauge what the ratio is whether there's a need for staged repair, whether it's greater or less than 0.57. Let me show you examples. In the top right-hand corner is a first trimester omphalocele. As I say, the echogenic tissue here inferiorly is bowel, the isochoic material superiorly is liver. I think I can see in most omphaloceles by simply looking at the echo texture whether it contains liver or bowel. If I look at this herniation, the circumference of the omphalocele is less than the abdominal circumference. In this case, in the bottom right-hand corner, I see the omphalocele circumference equals to the circumference of the abdomen. I'll play the clip. No, let me play. What is going on? The clips aren't playing. I'm not sure what's going on. No. Go back. Okay, I'm just going to share sort of screen share presentation and see if that solves my problem. Just bear with me. Sorry about this. I'm just wondering whether my cable is my problem.
You didn't share the screen as yet.
Yeah, I'm just going to do that. I'm going to share the presentation. I'm just trying to work out what the problem is here. So I'm just going to straight to sharing the presentation. Just let me ignite it. Let's get my videos working again. Okay, we're good. Okay, so just share. You still there?
Yeah.
Okay. So share presentation. Okay.
Yes, we can see now.
You can see now. Okay, good. Okay. So what I was showing you was in essence that when you look in the first trimester of pregnancy, you look at the size of the omphalocele reference. In this case, the omphalocele circumference is larger than the abdominal circumference. There's some noise interference there, Yassine. I think I'm hearing, if you can mute. And then here is an omphalocele that is larger than the abdominal circumference. So when you do that, you take the diameter and you take the circumference. Personally, I believe the circumference is of greater value in terms of prognosticating. And secondly, compare this image here to this image here, which is moving from a much lower frequency transducer to a much higher frequency transducer. This is a linear 9. You can see the definition of liver and the axis deviation of the fetal heart. So next I want to talk about gastroschisis. Now gastroschisis, we all see that as being a far more benign condition. Firstly, because in the first trimester of pregnancy, it's got a much lower association with aneuploidy. So you expect to see a thin nuchal translucency, very different to omphalocele. We expect more than half of them to have associated malformation. I generally see gastroschisis in younger women in the first trimester, more likely in smokers or those who have used substance abuse, particularly cocaine or the vasoconstrictors. This is showing you the typical appearance of loops of bowels sitting on the fetal abdomen in a fetus at 12 weeks of gestation or 14 weeks of gestation. But you know, I don't quite see it as being as a benign anomaly as I was brought up to believe, because I recognize that on more recent data that 10% of these have got unrelated anomalies outside their gastrointestinal tract. That's important because you need to screen for these. And the second is that many of these develop gastrointestinal complications, particularly gut atresias, and that's up to 1/3 of these fetuses after birth will develop gut atresias. I think patients need to be counseled about that in advance. This is another example of a fetus with the gastroschisis, where you can see a normal intracranial translucency, cerebral peduncles, thalmi, thin nuchal translucency, and here you see on the abdomen multiple little ripples or loops of bowel. It's discretely different to what an omphalocele looks like, because you're seeing multiple loops of bowel on the surface of the abdomen, because an omphalocele is smooth, except in the situation where it ruptures. A gastroschisis to me is a more difficult diagnosis. A gastroschisis, however, is a more difficult abnormality, because in situations the bowel is interposed between the fetal legs, and that can be much more difficult to identify. So you need to pay attention if you're seeing a collection of echogenic tissue in the midline between the fetal legs. You're not missing a gastroschisis. Somebody's mic is not muted. I'm not sure. I'm just getting some noise feedback. And then there's pentalogy of Cantrell. In pentalogy of Cantrell, it's in a sense an omphalocele, but there are other abnormalities with it. Cardiac extrophy, intracardiac defect, sternal or diaphragmatic defect, and a pericardial defect. These are difficult to see in the first trimester of pregnancy. So mostly it's a diagnosis by inference. If we see an omphalocele, if we see cardiac extrophy, then we make a call of pentalogy of Cantrell, because we cannot see the diaphragmatic defect nor the pericardial defect. One of the first clues you may see is a pericardial effusion. When you come across and look at this fetus, you can see here the widening of the cord insertion into the abdominal wall. In the bottom left-hand corner, you see here is the chest, but you can see the heart is pulsating outside, and you have here is your anterior abdominal wall defect. Similarly, in the top left-hand corner, here's your omphalocele, but you actually see the heart is pulsating. So anytime you are faced with seeing an omphalocele, it's important next to go up and look at the heart to see, number one, is it in the chest or is it in the or exteriorized as part of cardiac extrophy? And secondly, to check for axis deviation. It's very common in the large omphaloceles to see cardiac axis deviation, and this becomes an important thing in prognosticating and counseling patients. Then there's bladder or cloacal extrophy. So this is in the setting where you see an exteriorized bladder, frequently associated with an omphalocele, an imperfect anus, and a spinal defect. So once you see an omphalocele, the next step is after you've excluded on the superior end, there's no cardiac exstrophy. On the inferior side, you need to check that there's no bladder exteriorized. So in this fetus here, very early in pregnancy, you can see there's an anterior abdominal wall defect. It does not have a smooth border. It's irregular in outline. The next thing you need to ascertain is that hernia below the level of the cord? And that's the key message. So if you look in the bottom left-hand corner in this fetus, you will see that this is the cord insertion here, but the exteriorized organ here is inferior. And this is telling you that you are looking at a bladder exstrophy. So when you see an omphalocele with a bladder exstrophy, the next thing to look at is the spine and confirm that it's an OIES complex. Then there's amniotic band syndrome. And if there's ever a time in gestation to pick this abnormality, it's the first trimester. Because in the first trimester, we can see the amnion. In fact, the best time to make this diagnosis in the first trimester of pregnancy is at 10 weeks of gestation. Because at 10 weeks of gestation, you can see the amnion separate to the coelomic space. So this is the amnion here. The leg is inside it. But when you look, you see the liver and the bowel is exteriorized. And it's sitting here in the coelomic space, and this is the amniotic space. Secondly, when you look at the spine, you see that typical scoliosis, and that brings you may recognize this first as being a key landmark finding in a setting of a omphalocele. And then you can use 3D, which is the icing on the cake, because you can see the constriction band here, and here's liver in the coelomic space, cord, torso, and upper fetal body sitting in the amniotic sac. And there are variations of this. So this is a fetus where you can see an omphalocele here. Here's the amniotic membrane coming around here, but the liver is sitting out in the coelomic space. The thing that struck me when I examined this fetus was the very abnormal position of the legs. And then you've got exteriorization of bowel. You can see bowel loops here, and the bubble is the exteriorization of the fetal bladder. So that's liver, bowel, bladder, and that's all sitting outside in the coelomic space. So this is a case of a exstrophy with an omphalocele in the setting of an amniotic rupture sequence. They can get even more, these anomalies, you can pick them up even earlier. So this is a case of a amniotic rupture with acrania and exteriorization of both omphalocele and bowel. So here are the legs, 10 weeks and 5 days. She came in for a pre-NIPT scan. Here are the 2 feet, thigh and knee. And as I come up from this view, as I come up to looking at the abdomen, you can then appreciate here, this is liver, exteriorized here, and bowel. And play the rest of the clip, and then we move up to the head. This is liver, bowel, face, and then you can see the calvarium. I mentioned to you at 10 weeks, you should see ossification at the frontal bone, and there's no ossification with this cystic appearance to the fetal brain. And we've described in our unit the different sonographic appearances in the first trimester of acrania. And one of our subtypes was this cystic acrania. And this is an example of an omphalocele in association with a cystic acrania. So these very severe abdominal wall defects can be picked up very early in pregnancy. And finishing up, this is a fetus with a anterior abdominal wall defect, exteriorization of the heart, and you can see both vessels coming out in parallel. And if you remember pentalogy of Cantrell, one of the features is an intracardiac abnormality. So transposed great arteries with a cardiac exstrophy, and the liver is fused to the placenta. And then on looking on color Doppler, you can see here the heart pulsating outside the fetal chest. Some of them may be a little bit more subtle. In this one here, you see exteriorization of the bladder, an extremely short cord from here to here. And many of you will know that the cord is much longer than that in the first trimester of pregnancy. So looking at body stork, or if you want to call it short cord anomaly, it's frequently associated with an omphalocele with exteriorization of bladder and bowel and fused to placenta. It's a terrible prognosis. Frequently they have spinal defects and very abnormal positioning of the legs here, and a tiny length of cord leading on to the omphalocele exteriorized bladder. So a rare and but easy diagnosis to make in the first trimester of pregnancy. So I'd like to finish up by just mentioning about omphalocele. I mentioned that bowel herniates into the base of the cord and then returns. It should return by 12 weeks. And these all show examples of tiny loops of bowel herniated into the base of the cord in fetuses at 12 to 13 weeks of gestation. And it's important to recognize these. If you routinely look at the anterior abdominal wall and you've got your body or spine, your intrahepatic vein, you must look at the point of where the vein enters and look for a loop of bowel herniating into the base of the cord. It's at this point that you'll pick up these tiny omphaloceles, and in some of them they may be dilated, but also may be obstructed and present with dilated loops. Whatever, don't confuse these with multiple cord cysts. So this is a loop of bowel that's herniated into the base of the cord, but this is not obstructed bowel, this is just cord cysts. And these cord cysts can be quite striking and quite edematous. And this is the same fetus after birth showing the cord cysts that mimicked obstructed bowel in a fetus with an omphalocele minor. When bowel does obstruct, it has the exact same appearance. This is a fetus 11 weeks and 4 days who presents with multiple dilated loops of bowel. There are three key findings which you will see in bowel obstruction in the second trimester, and they're no different in the first trimester. Number one, the bowel is echogenic. Number two, the bowel is dilated. And number three, there's hyperperistalsis. There is a fourth sign which I would include, is that the fluid in the bowel is hypoechoic. In the second trimester, it's more likely to be echogenic, and especially in the third trimester, but in the first, it is hypoechoic, and that may make it easy for you to arrive at a confident diagnosis. And this is a patient who we saw very recently in the first trimester with multiple dilated loops of bowel, hyperechogenic, increased peristalsis. But you can see the texture of the fluid in the bowel is identical to what it is in the amniotic fluid. It is hypoechoic. So in summary, in terms of the anterior abdominal wall defects in the first trimester of pregnancy, I think it's important in your protocol to look at the point of cord insertion, examining the vein, understand that the vein is superior to the artery, recognize that when identify not only omphalocele and gastroschisis, but the other major anomalies in 100% of cases. Remember, there's a strong association with aneuploidy, particularly for omphalocele, not so much with gastroschisis, but for both we offer genetic testing. If the fetus is euploid and we make the diagnosis in the first trimester, we prognosticate by comparing the circumference of the omphalocele to the circumference of the abdomen. But more importantly, we look for the evidence of associated malformations and the association of genetic anomalies. For all of these anomalies that are capable with, are compatible with survival, it's a multidisciplinary team approach to abdominal wall defects where involve genetics and pediatric surgeons in counseling the patients how to manage them after delivery. And for many of these now, for abnormalities in general, we are freezing tissue as the new world of genetics expands at great pace. So I thank you very much for your attention, and I'll take any questions if there are any questions before I get my next talk ready. Yassine, are there any questions?
Yeah, there is only one question. Thank you, Dr. Simon. If this mother is in a place where she was not able to do a scan to see all this, can this condition be made right for this baby to have a normal living?
It depends on the abnormality. If you take gastroschisis, I would first of all say yes. The outcome for most gastroschisis is very good. I just made comment that it's not 100%, and that's what we need to be careful of, because I was brought up, I was taught that once you make a diagnosis of gastroschisis, we didn't offer amniocentesis because they were young mothers. There was no associated problems seen on scan, and we counseled them that all you needed to do is to squeeze the bowel back through the defect and a single purse string stitch would close. Now that is true for many gastroschisis, but there's a hidden statistic that the 10% of them have associated abnormalities and 30% of other external problems outside the gastrointestinal tract, but many of these are minor. So overall, I'd say for gastroschisis, if there isn't any of these testing available, frequent scans, genetic testing, that the outcome is very good for the vast majority and no aneuploidy. For omphalocele, I'm afraid it's not so good. If there's no availability to genetic testing, she chooses to continue, and it's chromosomally abnormal with an omphalocele. Generally, that tends to be trisomy 18, 13, and if not, a very significant megabase deletion or duplication. And this has got much deeper implications in terms of other organ system abnormality and mental retardation. And then you've got the group of omphalocele who are normal chromosomes. These generally carry a very good prognosis. What I don't understand when I read the literature is that if the chromosomes are normal and a fetus got an omphalocele, after a single or staged repair from omphalocele, they do extremely well. Yet the termination rate from omphalocele that are chromosomally normal is very high. And I think part of the reason for this is that obstetricians, fetal maternal medicine specialists and geneticists, because it's such a striking abnormality that you see on scan, compared to, say, a transposition of the great arteries or an agency corpus callosum, which are so subtle, we tend to think that the prognosis is terrible, and our counseling tends to follow suit. And that's why I think it's so critical in counseling a patient with an omphalocele that's chromosomally normal, when a patient's asking, doctor, should I continue the pregnancy based on what the outcomes are? I think you as an obstetrician shouldn't be answering that question. I think it's really a pediatric surgeon and what the experience is in your local center. What's the experience of the pediatric surgeon and what are their statistics in terms of outcome with surgery? Because in tertiary referral centers that provide quality and first world standard of care for omphalocele, I think the prognosis is very good after excluding chromosome abnormalities, and that's supported in the published literature.
Okay, Dr. Sumedha Wagmere, do you have any question? You just
I want to ask you that is there any specific diameter for calling it as a widening of the bowel, or is there any specific like that there are some loops of the bowel dilated, then only we'll call it as a dilated, or there is just mild widening, if we see then we'll call it a dilated bowel?
It's a good question. I think for the first trimester, no, other than in terms of bowel obstruction, no, there isn't a figure for the first trimester. It tends to be very black and white in the first trimester because of the degree of bowel dilatation that we see is very significant. And it also contains fluid and there's peristalsis. So I would say when a bowel obstruction presents itself in the first trimester of pregnancy, it's quite a straightforward diagnosis. But I would qualify that by saying, and therefore there's no measurement, but I would qualify that by saying many bowel obstructions don't present in the first trimester. It's only a small proportion. In fact, many bowel obstructions don't present in the second trimester. They present in the third trimester, or in fact, after delivery. With regard to the second trimester, personally, I don't rely on, I think David Nyberg was the first to report on a series of a length of bowel, I think was 15 millimeters, and for a width was 7 millimeters to make a call whether it was a bowel obstruction or not. And I think that was used as a guide to refer on to somebody who had expertise in recognizing whether it's pathological or physiological. In summary, for me, in the mid-trimester, a single measurement is not that important to me. What's far more important is, one, is it hyperechogenic? Two, is it a case where I'm seeing hypoechoic fluid? Three, is there a hyperperistalsis? And four, for most that are truly bowel obstruction, the degree of dilatation is very striking. I accept when I say that there's a separate subgroup of patients whose sonographers will call me and say, Simon, you come in and have a look at this, her bowel looks really prominent, she's 34 weeks pregnant. And I say, yeah, I agree with you, but it's meconium. And I rely very much for those ones that have slightly prominent loops of bowel by looking at the contents, then a measurement that's going to tell me whether it's bowel obstruction or not. And secondly, whether it's hyperechogenic or increased peristalsis.
Thank you.
But I would encourage you to look up David Nyberg for that paper if you want a figure. But I just don't know how reliable a single figure is. It's not like nuchal translucency.
Okay. Dr. Kauthar Hashim is asking, what is the normal size of the nasal bone?
We don't measure the length of the nasal bone in the first trimester. It's either present or absent. With regard to the second trimester, there isn't a single figure for the cutoff. There's a nomogram. So you would need to take out your Cicero's chart on nasal bone and look at the number of weeks and days of gestation and work out whether it's above the 95th centile. As a general rule, you know, at a 20-week scan, you should be seeing a nasal bone more than 5 millimeters, 6 millimeters. But to answer your question, there's a centile chart in print by Cicero. You need to refer to that in the second trimester, but there's no measurement for the first trimester.
Okay. Dr. Indumati is asking, can you please explain the measurement of AC and omphalocele mass? Was not able to follow.
Sorry, can you repeat the question, please?
Can you please explain the measurement of AC and omphalocele mass? Was not able to follow. In QA box, if you can read it yourself, in QA box.
Let me see the QA boxes if I can read it. Can you please explain the measurement of the AC and the omphalocele mass? Was not able to follow. Okay. What that paper, if you look at, there are two papers in that Tassin paper, and what they are simply doing is trying to ascertain a good prognostic group from a poor prognostic group. The poor prognostic group are the ones that have a lot of morbidity, a difficult time in the neonatal intensive care, and they require multiple surgeries. They're trying to separate that group from the group that were single repair, spent little time in the unit, didn't have feeding difficulties, didn't get respiratory difficulties, and they had a single operation to close their omphalocele. So they looked at the parameters that were most predictive of being a good prognosis versus a bad prognosis, and they found that by measuring the circumference of the omphalocele in relation to the abdominal circumference and using the cutoff of the ratio that I provided in that paper to determine whether the patient fits into a good or bad prognostic group. Can I add to that though? You must be careful in a sense when you can't rely on a single figure with anything in a sense with relation to omphaloceles. It's a useful guide in terms of counseling a patient, saying, look, listen, this is useful. But what's more important is, I think, is in the hands of an experienced person, there is subjective assessment of the size, the contents, the presence or absence of bowel dilatation, whether scoliosis, cardiac axis deviation, other associated abnormalities, or aneuploidy. These things for me are more important. But I think it's nice to have something that you can measure that gives me a feeling that if I'm going to go down the course of counseling this patient as a single operation repair with a favorable outcome, that I've got something that I've measured and documented and put it in my report to back it up, my subjective assessment. And that's the role I see for it. Does that make sense? Can a small omphalocele be corrected postnatally? Yes, yes, it can. What you need to be very careful about these, Poonam, with regard to your question, yes, they can. What you have to be very careful is once you make a diagnosis of a small omphalocele minor, is that you say to the midwife, make sure you don't place the clamp on the cord too close to the cord insertion site, but they can be easily pushed back in with a single purse string suture. That's for the minor. For the major, I've already answered the question, but your question was the small omphalocele thing, can it be corrected? Absolutely, very straightforward. Single purse string suture, push the bowel back in, but just make sure that the obstetrician knows about it and the neonatologist knows about it and the midwife knows about it. They don't end up clamping bowel that is in the cord. Not such a good thing to do.
Okay.
I better move on. It's 11:45 here. I better keep going on to my last talk.
Yes, please.
Okay, so a practical guide on fetal cardiac anomalies. So we'll cover this in half an hour. So the talk is divided into introduction and guidelines. I want to cover the golden rules of cardiac imaging because this is what's so important. And then on to the stomach, the fourth chamber, the left ventricular tract, three vessel tracheal. And then I'll finish up with some summary and some comments. So the first is with regard to anything we're doing in cardiac imaging, it relates to pattern recognition. Now, some of you will be attending this and straight away you will recognize these anomaly sequences.
Dr. Simon, you need to stop if you share screen, then you need to share it again. Yeah.
No problem.
Because the old slides are showing.
No problem. Okay, have you got it?
Yeah.
Thank you. So with regard to imaging the heart at the mid-trimester and the first trimester, there are various sections which we recognize. And many of you on this webinar this evening will know these sections. And the reason these sections were introduced was simply because we recognize our detection rate of cardiac abnormality was poor, number one. Number two, that imaging the heart is extremely difficult. And number three, the way to image the heart in a screening context is axial imaging. So a section analysis through the fetal heart. And by recognizing the landmarks going from the stomach, which is section number one, to the fourth chamber view of heart, number two, to the left ventricular outflow tract, number three, to the three vessel view, number four, which is also this vessel section here, four, outflow, right ventricular outflow tract, and then to the fifth section to the three vessel tracheal view. And by doing this allowed us to incorporate examination of the outflow tracts as well as the fourth chamber view. So that's what we all do in clinical practice. And our detection rate of cardiac malformation has greatly enhanced. So what does that mean to you as a practitioner? It means that you have to systematically look at these sections. And what I want to do is to go through these sections and show you the anomalies that you may identify on these sections, because that's what you want to know as a clinician. Most of you are obstetrician, gynecologists or sonographers or radiologists who want to pick the needle out of the haystack. Because once you pick the needle out of the haystack, it's going to be a pediatric cardiologist that is going to walk through and classify what the anomaly is. Or if you're somebody like a maternal fetal medicine specialist and you actually want to delve into that arena of fetal echocardiography, I would suggest you go well beyond the ISUA guidelines, and I would suggest the AIUM practice guideline, which is a very detailed guideline on how to examine the heart. And that's something, if you're an enthusiast in fetal echo, that I think you need to read and know from back to back. With regard to the heart, I think starting out, wherever you are in your training, I think it's always a good idea to know what the job is at hand, or if you're well into your training, have a classification system so you can break the heart into these different sections. Because when doing so, your next step is how do I recognize these on all the sections? So you've got the left heart, the right heart, the override, the septal, spatial arrangement, the venous. These are really rare. I don't think I'm going to even mention those. Soft markers don't count and borderline finders don't count. Heterotaxy, when I say don't count for the purpose of this lecture, heterotaxy is a mixture of the previous anomalies. So if we just get rid of these, this is what you need to know. The left heart abnormalities, the right heart abnormalities, tetralogy of Fallot, double outlet, common arterial trunk, which are the override anomalies, the septal defects, which are ASDs and VSDs or AVSDs, and then the spatial arrangement, which is really transposition of the great arteries and congenitally corrected. And then there's these venous anomalies. So if you sit down one day and say to yourself, what does that add up to? If you just have the big ticket items, which are these big ticket items, it adds up to about 30. And then if you chuck in the other, maybe a little bit less than that, you throw in the others a little bit more, somewhere about 45. What I suggest you do is you go down through sections 1, 2, 3, 4, and 5, and ask yourself, which of those anomalies can I see in which of those sections? If you spend a couple of hours doing that, or if you just take even this page, take a snapshot of it, and look at the anomaly and ask yourself, this is what happens in all the sections, you'll find yourself very quickly feeling a lot more comfortable about imaging the heart. And that's what I want to do now, is to walk you through those sections and say to you what you should be looking in the section of the abdomen, the 4-chamber, the 5-chamber, the 3-vessel and 3-vessel tracheal view. Normally I would do this in a day, a full day of 8 lectures, but I'm doing this in 20 minutes. So strap yourself in and hang on. But what I do want you to take home is, as you go through these sections, there are some golden rules that will allow the penny to drop for you in recognizing, as you go through these 5 sections, what are the anomalies. The first rule is that if you look at a 4-chamber view of heart, the thing you need to focus on is the very beginning of the scan is the descending aorta. No matter how large a patient is, almost always you will be able to see a 4-chamber view, and almost always you will be able to see the aorta. No matter what position the baby is in, cephalic, breech, transverse, spine up, spine down, lateral, you just have to identify the descending aorta, because once you see the descending aorta, from that point on, you know exactly where you are. Without having to worry about where the stomach is, spine, face, you know that out straight in front of the descending aorta is the left atrium. That's a very powerful golden rule in routine cardiac imaging. Rule number 2 is when you look at the 3-vessel tracheal view, so you're sweeping from a 4-chamber 3-vessel tracheal view, you see the trachea. And the vessel that's close to the trachea is almost always the transverse aortic arch. The only exception to that is with a right aortic arch with a right arterial duct. That's very rare. So let's forget about rare. Let's just think about tomorrow morning. Is that on a 3-vessel tracheal view, once you see the trachea, you know that's transverse aortic arch. That's a very powerful piece of information, because if you know that's the transverse aortic arch, you know that this is the main pulmonary artery, and you know that that is the arterial duct. Why is it powerful? Well, because if I see red here coming up through the transverse aortic arch, I know which side my obstruction is on. If you look here, I see red coming up through the arterial duct, I know which side my obstruction is on. And firstly, I know there's obstruction that is going to require prostaglandin. So in a hypoplastic left heart, whatever the cause is, whether it be hypoplastic left heart syndrome, which is mitral atresia with aortic atresia, or critical aortic stenosis, which is related to cardiac fibroelastosis or aortic valve stenosis, or mitral stenosis with VSD, I am going to see reversal of flow along the transverse aortic arch. And this will be enlarged, the pulmonary artery. So before I even get to the 4-chamber, if I go in tomorrow morning and do a scan, and I see that here is the trachea, I know if I see red here, that feature's got a hypoplastic left heart syndrome until proven otherwise. If it doesn't have that, it'll have mitral atresia with VSD. If it doesn't have that, it'll have critical aortic stenosis. If it doesn't have that, it'll have coarctation. And similarly, for the opposite side will be anything that gives rise to pulmonary atresia, Epstein's anomaly, pulmonary atresia with intact septum, severe or critical pulmonary stenosis, and so on. So that's why that's so powerful, because once you've got a cardiac abnormality, you want to know, have I just lost you? Are you there? Are you there? Are you still there?
Yes,
We can see you, but you're not sharing.
Okay, thank you. Okay, just bear with me, please. Okay. So that's the power of the three. Have you got my screen?
yes, we can see.
Thank you. So that's the power of the three-vessel tracheal view. The next golden rule is looking at the inflow into the ventricles, is setting that every scan that you do is that red is set upwards and blue is set downwards. So anytime I do a scan, I will ensure that inflow is always red and that outflow is always blue. Now, the reason that is a powerful golden rule means that tricuspid valve regurgitation, I can't draw in blue with this pen, but pretend that that's blue, but tricuspid valve regurgitation for me is always blue. Red fill, blue jet, red fill, blue jet. I know from the forward flow in the pulmonary artery and the transverse or ascending aorta is always blue. If I see any red in there, I know the most common reason for that is my PRF is incorrectly set, or either I've got a valvular lesion, either a pulmonary valve lesion or aortic valve lesion. So understanding that every single scan that you do, if you set your system the same way for every scan, it becomes automatic when there's turbulence in flow. And for many cardiac abnormalities, there's turbulence or reverse direction of flow. And I'll touch on that with examples. The next golden rule, number 4 in cardiac imaging, is you have to understand PRF. And for that, you have to understand that in a fetus, the velocity of flow changes every week of gestation. It gets faster. So when I talked about doing a scan at 11 to 14 weeks, I said, set your PRF at 25 to 35 centimeters a second. The reason I said that is because that is the velocity of flow, the median velocity of flow at that stage of pregnancy. When you do a scan at 18 to 20 weeks of gestation, you should set your PRF around 55 to 65 centimeters a second. And if you're doing a scan, say 35, 36 weeks, around 85 centimeters a second, 75, 85. So in other words, for every scan that you do, you must understand that the velocity has to be set for a PRF that represents the velocity of flow in that fetus. Because if you don't understand that, you can't image the heart properly. The second golden rule is that when you understand the velocity of flow in a fetus from 10 weeks of gestation up to 40 weeks of gestation, you will see that the peak systolic velocity seldom goes over 100 centimeters a second. Nobody images the heart at 40 weeks gestation for the heart. It's the time where you're going to be imaging is in this landmark for most of us, is the mid-trimester morphology, and then later on. So the figure you should carry around in your head, which is very useful, is 100 centimeters a second. If you ever find that the velocity at your correct PRF setting is more than 100 centimeters a second, then you know that you're looking at a valvular obstruction, whether it be aortic or whether it be pulmonary. And I'll give examples of that as we go through. So understand, 1, what the PRF setting is for the weeks of gestation. I've just read them out to you. 2, the velocity is seldom greater than 100 centimeters a second at the time frame where we are examining the fetus. And that's just a very easy figure to carry around in your head. If it's more than 100, then take out a chart and chart it where it is on the centiles. For most of us nowadays, we don't use Rizzo's chart, which was centimeters per second per weeks of gestation. We Z-score. And this is a publication which I don't have the time to go through, but I suggest you read. But Z-scoring the pulmonary artery diameters and the pulmonary artery velocities. In fact, everything in this cart we now Z-score. And why do we do that? Because we want to track change over time. And the best way to track change over time is to reference these parameters of velocities or change in size of vessel to other fetal parameters, whether it be BPD, femur length, estimated weight, and Z-scores allows us to do that. So it's a more accurate representation of what a velocity change is over time. Golden rule number 5. When imaging the heart, I think it's a good idea to split the screen. When you're looking at a heart, you can have on one side color and the other side beam mode. This is particular. I haven't shown a great example as a muscular VSD, but it's really best for looking at valvular abnormalities, semilunar and AV valves. So looking at tricuspid valve regurgitation, Epstein's tricuspid valve dysplasia, aortic stenosis, pulmonary stenosis. When you see the 2D and the color compared side by side, you can see where the turbulence relates to the valve movement. Or in the setting of this, I've given an example in a muscular VSD, in the area where you see color, you actually can't see any evidence of a defect on 2D. So you know you're looking at a small muscular ventricular septal defect. In sizing muscular VSDs, you reference these to the aortic valve. And I'll give an example of this a little bit later in terms of the need, whether or not for surgery. Golden rule number 6. When looking at the heart, it's important to understand the relationship to the pulmonary artery to the right ventricle. The left ventricle is so much easier when compared to the right because the left ventricular outflow tract is continuous with the interventricular septum. So the LV and the LVOT are much easier to understand because you see that continuity of the anterior wall of the aorta, the interventricular septum. The problem with the pulmonary artery is once you look at the pulmonary artery, the right ventricle disappears out of view. And therefore, it's much harder to image the pulmonary valve. Because you see the left ventricle in continuity with the aorta, you can almost always see the aortic valve, whereas the pulmonary is harder. So I would suggest when you're sweeping from the 4-chambered heart to an outflow tract is you try and get the free wall of the right ventricle in view. So here's your 4-chamber, and I'm going to start. My first golden rule is that this is your descending aorta. So without knowing what is left, right, up, down, I know that's the left atrium, and therefore I know that's the right ventricle straight away, without referencing where the stomach or position of the fetus is. And that's the power of seeing the descending aorta in relation to that left atrium. I can see my free wall of the right ventricle here. And when I sweep, I want to be able to have the free wall still in view. And then once I do that and see my pulmonary artery, then I can identify the pulmonary valve. Because so frequently I see sonographers and imaging specialists showing the pulmonary artery and the 3-vessel view, and there's no pulmonary valve in view because they've gone too high, because they have not shown the right free wall in view. If you really want to image the pulmonary valve properly, you have to show that. That's golden rule number 6. Next golden rule is in a situation where you are suspicious of any valvular disturbance, is place the pulse Doppler gauge over the vessel where you're concerned and straight away switch from that vessel to the other great vessel. So in this case, it's a aorta, which is demonstrating velocities of over 120 centimeters a second. So straight away, no matter what the gestation is, I've reached my mark of 100. If I find a pulse Doppler that's more than 100, for me, I've got a valvular problems until proven otherwise. Because if I look at Rizzo's chart, the original chart, at no gestation do velocities other than over 40 weeks go over 100 centimeters a second. This is a fetus with velocities at 120 meters a second. That's not right. But somebody taps me on the shoulder and says, Simon, hang on, don't you get false positive calls with Doppler where it says it's raised, but it's not? And I say, yes. Well, how do I know that that's not a false positive? I say, well, the way you know is you swap over from the pulmonary artery to the aortic artery to the pulmonary, and you have velocities in the same features of 45 centimeters a second. So straight away I know that in the aorta it's 120 and the pulmonary is 40. Well, that tells me that the aortic valve is abnormal. Whereas if the pulmonary valve, I got over 100 centimeters a second, well, then I would be suspicious that both valves having stenotic lesions together is a pretty unlikely event. Then I would say it's more likely to be a Doppler error, artifactual error. So what's my take-home message? If you're ever in doubt about seeing what you are suspicious of being a stenotic lesion, don't forget to compare one to the other, the aortic and the pulmonary. Secondly, when you look at a stenotic lesion with raised Dopplers, you'll see the complex is filled. Where you see at the heart of this complex, it's chilled out. You can see it's dark in the center. That is laminar flow. So in laminar flow, the typical appearance is it's hollow in the center, hypoechoic, whereas turbulent flow, it's hyperechoic throughout the spectral Doppler. Golden rule number 8. In your technical setup of your golden rule number 8, make sure you know your settings. Don't just go in and press the cardiac button and hope that that will save the day. I think it's important to understand the contributions of all of these because you are regularly changing. This here is probably the most important one, is to select, and I've shown examples of that throughout my talks this evening. And for cardiac imaging, I use a C2 to 9 probe and a linear 9, and I use them with equal frequency, and I use them both not just for second trimester. Then there's a harmonics, and many machines come with presets with the harmonics and frame rate. Contrast, I'm changing that. Mainly with dynamic range and contrast, I'm changing. Persistence is a preset, is generally there. Single focal zone, I'm changing all the time. My sector width, I'm changing all the time. And depth, I'd use over zoom. And cine loop, I use all the time. And of course, color is encouraged. And I've mentioned the importance of transducers. And this is the juice I'm using here, C2 to 9. It also comes in a 4 to 8 or the linear 9 probe. And for the first trimester, the 6 to 12 or the 5 to 9. So let me just show you why that's so important. This is a fetus at 21 weeks of gestation. The first thing I want to show you is that this is the trachea. So this tells me straight away, here's my spine, my vertebral bodies. If that is the trachea, without knowing anything about what position the baby's in, without knowing anything about the 4-chamber view of heart, I know that that's the transverse aortic arch. And I also know that this is the ductus arteriosus. I know this is the main pulmonary artery. I also know that there's forward laminar flow. Why? Because I've set my preset that red is up. And I know that the spine is down. And I press play and I see blue laminar flow across the transverse aortic arch. I know that my great arteries are normal. I've got laminar flow. I know that's extremely unlikely that I'm going to have any obstructive lesion on either my left or my right side. I do, however, note that instead of having 4 vessels, I've got 1, 2, and I've got 4 vessels here. I'll come back to that when I do my section analysis in a second. But what I want to show you is that this is the image from this transducer. In a second, you will have the image from this transducer, and next you'll have the image from this transducer on the same patient. I swapped between transducers in this examination. So watch what frequency gives you when you look through this case and how the resolution of the image improves. This is a bilateral SVC, a normal transverse aortic arch, now moving to a linear 9. The detail, suddenly this becomes a lot larger, the laminar flow much purer, and now I'm using up onto an ML 16 megahertz. Look at the size now of the persistent left SVC, and I can see the left SVC draining down into the coronary sinus, and not only can I see it, I can see that there's laminar flow in a persistent left SVC. You will never see that with the linear 9, 4 to 8, or 2 to 9. You will see it firing at 15 megahertz at 21 weeks of gestation. So that's the power of frequency examining the heart. In the first trimester, this is examining a heart with a 4 to 8 probe. When you look at this 4 or 6 to 9 probe, when you look at that, some of you in the room may think that looks abnormal. Some may say, I can't see anything. But if you look at it, it's hard going. But if you swap over to a higher frequency probe, you have the descending aorta here lying to the left of the spine, therefore that's left atrium. This here is your left ventricle, and this is right ventricle. Your right ventricle is smaller than, your left ventricle is smaller than your right ventricle. This is a hypoplastic left heart. The only reason I appreciated that was because I used a linear 9 probe. It's just simply far more difficult to appreciate. When you go back and look at it now, you may say that that left cardiac ventricle is smaller, but really on the linear 9 it's much easier. And why? Because it's a 12-week scan, but it's so much easier to see the higher the frequency you go. Rule number 10. When you look at the heart, the first section you look at is to see that the stomach is on the same side as the heart. And I suggest you do that as a split screen. So you image the stomach and the heart in the same image using a split screen. And you know I use split screening for a lot of my imaging. It just ensures that everybody does the same thing, and it ensures that you have a systematic approach to imaging. So in this fetus here, you can see you establish that the spine is here. By looking at the head and spine, you establish that the stomach is on the left side. You split your image, and now you realize you draw a line through the vertebral body that the heart is predominantly in the right chest. You also may appreciate that there's a single ventricle heart. This is a fetus here on the left side of the screen in the first trimester of pregnancy. So you see that this is your stomach here, but you notice that the heart is on a different side to the stomach. So you split your screen, and as you demonstrate, you've got the heart on one side and the stomach on the other. Medico-legally, you have documented and a piece of information that states that you checked situs at this examination. Rule number 11. In examining the heart in the first trimester of pregnancy, I encourage you to use color. I've already made mention of this. These your guidelines say do not use color. That will change soon. We clearly see the benefits of color outweigh the concerns regarding the mechanical and thermal effects. And to show you the power of color, this is a 4-chamber view of heart with a linear 9 probe. It not only gives you the inflow into your right and left ventricle, it gives you inflow into the atria, it gives you your pulmonary veins, it defines the atria and defines the interventricular septum and defines the size of the ventricles. It also shows you that there's an aberrant subclavian artery, shows you the trachea, the left brachiocephalic vein, subclavian artery posteriorly, the vein anteriorly, and similarly here, the vein anteriorly and the artery posteriorly. So the vein is anterior and the artery is posterior, and here's your aberrant subclavian artery tracking behind the trachea. So that's the power of color, and this is at 13 weeks of gestation. Similarly here, coming up from a 4-chamber view of heart up to a 3-vessel tracheal view, you see that U configuration of a right aortic arch. And now I split my image showing B mode. You can see how I would not have made that diagnosis on 2D. And you can see that how using color, I can see there's a right aortic arch. And then using slow flow technology, I can see the artery on both sides posteriorly and the vein anteriorly and the internal thoracics in a fetus at 13 weeks of gestation. So I encourage you to use color in the first trimester of pregnancy is my take-home message. Rule number 12. In rule number 12, when examining the heart, it's important not to go home thinking that you've covered it all because you've demonstrated the 4-chamber view of heart looks okay, and then you sweep, you see a pulmonary artery. You see your pulmonary artery coming out, your aorta and SVC. But this heart is actually abnormal. So it just makes the point when you look at when you're looking at the heart, you have to try and aim to have the apex up at 12 o'clock and image the 4-chamber view of heart before you pack your bags and go home. Because you will miss ventricular septal defects, you will miss atrial septal defects, you miss Epstein's. Because if you wait for this fetus to rotate into a better position, or when I say wait, you push the fetus, cardiac imaging involves 2 hands, where you will appreciate that there's an AV canal defect in this fetus with regurgitation coming predominantly on the left side. How do I know it's left? Because that's the descending aorta, which defines the left atrium. That's the left ventricle. You will also note regurgitation is blue. Regurgitation for me is always blue. Why? Because I've got red set up, inflow is red, and regurgitation is away from the transducer is blue. And that's my regurgitant jet. But if you look at these 2 hearts examined on the same day, only minutes apart, how normal it looks with the apex at 3 o'clock and how abnormal it looks with a complete bite missing. It's not a partial AV canal defect. This is a complete AV canal defect. My take-home message, when looking at the heart and routine imaging, have the apex up at 12 o'clock. I know that's not possible in every world, but it is more possible than you think if you push the fetus into that position or if you have the patience of time. Rule number 13, when you suspect that there is a VSD or AVSD, I think the next step is to try and get a short axis. Getting a short axis of the heart for obstetrician is frustratingly difficult. And I wish somebody had told me this rule a little bit earlier in my training. But if you're going to get a short axis view of the heart, do not have the apex up. The opposite of what I was saying earlier on. For looking at a short axis, you want the apex of the heart at 3 o'clock or at 9 o'clock. When it's at 3 o'clock or 9 o'clock, you simply flip your transducer. You rotate it 180 degrees, and then you will get a short axis of the heart. And then you will be able to see your mitral valve here and your tricuspid valve here. So if you look in this fetus, we come up on a short axis, you will see the moderator band here. So that tells you you're in the right ventricle, and that's important, particularly with congenitally corrected transposition. But this is a complete AV canal defect. As you come up on a short axis, you see there's a common valve opening and closing. And this is how I work. There it's open, closed. This is how I work out whether it's a complete or partial AV canal. And you can see you've got a complete defect here. So when you see dropout and you're trying to work out whether an atrium partial or complete, the only way of knowing is by going to this section here on a short axis. And the only way you will get the short axis show that it's complete is by having the apex of the heart at 9 o'clock and then flipping your transducer. There's no other way of getting it. And I think that is rule 13. I think it's the end of my rules. I think for stick evaluation, just let me say that I think the role of stick evaluation in the fetal heart relates predominantly to fetal echo. It's not a screening tool. For those of you interested in fetal cardiac diagnosis, once you pick the needle out of the haystack, then applying stick technology has got great value. So this is an example of a heart on 2D showing that there's an atrial aneurysm at 13 weeks of gestation. How do I know it's a right atrial aneurysm? Because I know that that's the descending aorta, and therefore that's the left atrium, left ventricle. Here's my moderator band inside my right ventricle, and here's my dilated right atrium. What's interesting in this case is that the AV valve is not displaced and not dysplastic, and these generally carry a very poor prognosis in the first trimester and seldom seen in the second trimester. They succumb in the first trimester. This is a stick showing a ventricular septal defect and showing the pulmonary artery crossing over the aorta here in red and continuing around the corner of the aorta to join to form the 3-vessel tracheal view. And you can see the neck vessels coming off. Now you can't achieve that in color. You can only achieve that on a 4D or stick assessment of the heart. And this is a 13-week fetus with a muscular VSD with a right atrial aneurysm showing otherwise normal ventricular, arterial, and venoatrial connections. So it just shows you 2D and color stick, the power of it in the first trimester of pregnancy, but it really is not in a screening context, it's in cardiac diagnosis. So in terms of screening for cardiac malformation, the sections we look at are the stomach being on the left-hand side, the aorta to the left spine, IVC anterior to the right, looking at the 4-chamber view of heart, ensuring that the moderator band is on the right side. The left ventricular outflow tract showing the anterior wall of the aorta is continuous with the interventricular septum. And on the 3-vessel view, showing that the aorta is larger than the pulmonary artery, is larger than the SVC, and then the 3-vessel tracheal view. I think I've gone a little bit over my time, so I'm just going to go through 1 or 2 examples of each. I won't be able to cover all of this. So this is the stomach on the left-hand side here, and we find here that the heart is on the opposite side. So that's one of the most important things about assessing the abdomen, is to check its relationship between the stomach and the heart after confirming the stomach is on the left or right side. In this case, the stomach is on the right and the heart is on the left. So that's an important thing to do. And the way I do when I start hearts, I know my 5 ischio sections, but before I start into my 5 ischio sections, I do a thing called SARS. So that's size, axis, rate, rhythm, and situs. And I do that before I go through my anatomical 5 sections. So in terms of working out my situs, it's establishing where the stomach is. And for that, I use the head and spine. And then I split my image showing my stomach and my heart. And I've already made reference to that. That's the first advantage of the first section of the stomach. The second is looking for the intrahepatic vein. So you look, this is the stomach on the left-hand side, and you see that the gallbladder is here and the intrahepatic vein is here. And this is abnormal. This is a persistent right umbilical vein. This is a about 8% of these will have an associated congenital heart defect. And therefore, when looking at the level of the stomach, it's important to identify these. This is the normal configuration where the stomach is here, the intrahepatic vein sweeps away from the stomach, and the gallbladder is on the opposite side. Whereas on persistent right umbilical vein, you have the stomach and the gallbladder is interposed between the intrahepatic vein. So if you run this clip again, you can see the stomach, gallbladder, and intrahepatic vein. It's the wrong order. The gallbladder should be on the opposite side. The intrahepatic vein should come in and sweep away from the stomach. So as soon as I see that, the next thing I do is I go to the heart. The next thing after seeing a persistent right umbilical vein is I look for another venous anomaly, either an absent ductus venosus, a persistent right superior vena cava, and so on. Persistent right SVC, and so on, or interrupted inferior vena cava. And you can use, it's got a patient's name, please excuse me, let's skip that. So next move to the 4-chamber view of heart. And for many of you will be familiar with all the abnormalities that you can pick up in a 4-chamber view of heart. So for this here is the descending aorta. Straight away, this tells me it's a hypoplastic right heart. And in this bottom left-hand corner, I come on here, this is the descending aorta here to the left of the spine, defining the left atrium here. From there, I reference as to where I'm going to go. And I look here, I've got a small left ventricle when compared to the right ventricle. So this is a hypoplastic left heart. So that's by using my rule of the descending aorta. Other things that you'll see commonly looking at the 4-chamber view of heart is dropout of the interventricular septum. There are 3 key things you're looking for there, which is dropout, edge enhancement. The dropout is hypoechoic. The edge enhancement is the echogenic border here seen on both sides. More commonly, you see that on the far side. But in the typical VSD, if you want to be very confident, you see it on the near as well. And the third thing you see after that is a color wash. So dropout, edge enhancement, and a wash of color are the 3 things you look for in identifying a ventricular septal defect, whether it be muscular, as in this case, or perimembranous. As soon as I see that, the next rule is I go to a high frequency probe, because I know that once I see one muscular defect, I look for another. And here's the second defect just here. So this is the one you spotted with a lower frequency probe. And once I pull out a higher frequency probe, I can appreciate that there's a second muscular. And the next thing I do after that is I look for a third, and so on. Once you've got that, the next step after that is to look for a wash of color across the septum. So as you come across here, you look with color Doppler. Ideally, if we're looking at a wash of color across the septum, I prefer to have the apex up around 11 o'clock or 1 o'clock. It wasn't possible in this fetus. But as I was looking at this, you could see there were 2 washes of color. Sometimes you will find that there's a single entry point and 2 exit points, or 2 separate entry and exit points. And that's because the anatomical structure of the ventricular septum, it's not smooth. It's like layers of fishnet where flow can go in one side and come out in a different direction. Important is not so much whether single or multiple for most of these. It relates to the size of the VSD. And as a general rule, if you ever have a muscular defect that's the same size of the aortic valve, you're generally looking at something that's going to go down the lines of surgical repair. And there are various ratios that are used to predict repair. You can see with the newer technologies, VSDs even earlier. So this is about a 4 to 5 millimeter heart, which is a 10 weeks of gestation. And you can see an apical muscular VSD. And we see these in the setting of increased nuchal translucency. We do not routinely use color in imaging the heart at 10 weeks of gestation. It's only in the high-risk pregnancies. About 1% of pregnancy at 10 weeks will present with an increased nuchal translucency. And we presented that and published that recently in prenatal diagnosis. So that's the group that we look at for VSDs. So when you look at this heart, you may straight away say, I know what that's going to be, tricuspid valve regurgitation. And I'd say, no, it's not. Without looking at left, right, or anything, I go straight for the descending aorta. And that tells me straight away that that's the left atrium, and that's the left ventricle. So that's mitral valve regurgitation. Mitral valve regurgitation is rare. Tricuspid valve regurgitation is common. That's probably why you went straight for saying this is tricuspid valve regurgitation. Mitral valve regurgitation, as soon as I see it, I think of critical aortic stenosis. Tricuspid valve regurgitation, as soon as I see it, I think, well, that's a normal cardiac variant. 5% of fetuses have got tricuspid valve regurgitation. So the next step in seeing this is I want to know is what is the left ventricle looking like? So this is the descending aorta, left atrium, left ventricle. When I look at that 4-chamber view of heart, there are a number of things I'm looking at. I'm looking at the cardiac apex, and I see that the cardiac apex is not actually formed by the left ventricle, it's formed by the right ventricle. That concerns me. I also note that this left ventricle is contracting very poorly. I also note that the interventricular septum is ballooning into the right ventricle. And this is a feature of a critical aortic stenosis. But you see, if you didn't look at these individual landmarks, how easily something like this could escape you as being a normal 4-chamber view of heart if you didn't put on color and then see that regurgent jet. If you haven't set your PRF correctly, that PRF is set at 56 centimeters a second. If you had your PRF set at 120 centimeters a second, you may not have appreciated that that was correct. So it's the importance of getting your PRF setting for your weeks of gestation. You will only find valvular or turbulent flow if your PRF settings are correct, will stand out. Otherwise, it'll just get blend in with the mess of turbulence in the background if your PRF is not correct. So here we have all the features of a 4-chamber view of heart. I'm just going to call them out as I go through. The descending aorta to the left. Here are the pulmonary veins entering into the left atrium. Here's a tiny little speck of tissue at the level of the AV valve projecting upwards, which is the atrium primum. A separate one comes down from the root secundum, and then the foramen ovale, which goes at less than 50% across the intraatrial septum. So this is the septum. It goes, balloons less than 50% across the left atrium. I'm mixing up my words here. It's sort of heading towards 1 o'clock in the morning. So here is your left atrium, a moderator band on the right side. Size axis, rate rhythm, situs are normal. But what concerns me as I look at this heart, as I sweep, is that there's dropout in the region of the atrium primum. Now that can be a very easy thing to miss. It can also be a thing you can readily mistake as being the coronary sinus. So as you look inferiorly in the heart, you will see the tram tracks of a coronary sinus going straight across in a normal fetus. And if you think there's dropout in the septum, it's probably that you're too low. You need to come up a little bit higher. So in this fetus, I came up a little bit higher. I lost my tram tracks, and I still have dropout in this area just here. And now I'm suspicious that I'm looking at an atrium primum septum defect. So to work out whether I'm truly dealing with an ASD or not, I rely on color. In the setting of an atrium primum ASD, the flow will be from the right to the left side. So if this is the descending aorta and this is left, and this is here is the right, I'm looking flow from right to left. So that's going to be flow away from the transducer, which is in blue. So this is an atrium primum septum defect. And this is the coronary sinus, which I'm saying you could easily confuse it with. So you look at the coronary sinus flows from left to right. This is the descending aorta, the left atrium, and this is flow from left to right. So if you ever see dropout, the take-home message is if you ever see dropout in the region of the atrium primum just here, you ask yourself, is it an atrium primum septum defect, or am I simply looking at a normal coronary sinus? Number one, you need to come up higher in the heart, away from the coronary sinus, and look for continuity of the atrium primum to the AV valves. And if it's discontinuous, then confirm it with color. I think that's probably enough. Just to talk about the area behind the heart. There are 4 things you need to know about the area behind the heart. This is a 14-week fetus, and you see a common venous channel being drained by the pulmonary veins. And this is a fetus with total anomalous pulmonary venous return. This is the descending aorta defining the left ventricle, which is small. So it's a hypoplastic left heart with total anomalous pulmonary venous return. So this is very abnormal. So the area behind the heart strikes you as seeing that common venous channel. In this area behind the heart, there should only be one vessel, which is your descending aorta. But there's a vessel of equal size to the aorta that will be an azygous continuation of an interrupted IVC. And that's a feature of left atrial isomerism. So the first clue you may get of left atrial isomerism is by seeing 2 vessels behind the left atrium. The other possibility to explain this is simply just an isolated finding of an interrupted IVC with azygous continuation, which is a normal variation in the human adult population of no clinical significance. The next you may see, what are 3 vessels behind the left atrium? Well, One will be a persistent left SVC, will be aorta, see whether it's pulsating or not. If this is not pulsating, it'll be your azygous continuation of IVC or your esophagus. It's more likely that this is your beg your pardon, this will be your esophagus, your aorta, and azygous continuation. You simply just wait and one of those will disappear. So it's just you happen to catch this at the point of fetal swallowing, because it's impossible to have 3 vessels behind the heart. And then the other finding which you may notice behind the heart when you see your descending aorta is if you see any vessels come across onto right and left heart is multiple arterial pulmonary collaterals, and this is in the fetus that's got no right ventricle, and pulmonary arterial collaterals, where everybody talks about looking for them. On sagittal or coronal imaging, they can be readily seen on a 4-chamber view of heart looking at your descending aorta, so don't forget to examine that. So moving then on to the last 3 sections, the left ventricular outflow tract, you look for the anterior wall of the aorta, continuous with the interventricular septum, and you're looking for laminar flow. The key things you're looking for there is the loss of continuity. So if the aorta sits astride the ventricular septum, this may be a feature of either tetralogy of Fallot, double outlet right ventricle, or common arterial trunk. So as soon as I take an image tomorrow morning showing a 5-chamber view that shows the anterior wall of the aorta continuous with the ventricular septum, I know that those 3 conditions are not present. It's very reassuring. The next thing is I see that I look at the caliber of the aorta and I look for the appearance and disappearance of the valve. So I'm looking for any evidence of coarctation or aortic stenosis. For aortic stenosis is a diagnosis that you make on collar Doppler examination. So I'm looking for turbulence. So in this case, if I ever see turbulence, there's a tiny little bit of turbulence there. I see my PRF is at 70. I'll increase my PRF up to 100. If I still see turbulence and my PRF is set at 100, I then know that I'm likely to be looking at a stenotic lesion. I then will place my pulse Doppler gate distal to the valve and take my peak systolic velocity. And if it's raised, if it's more than 100, I then Z-score it. If it's over that, I'll then go to the pulmonary artery and compare the Doppler. If I find that the pulmonary artery of 40 centimeters a second, I'm now seeing both aliasing, turbulence, and pulse Doppler, then I know I'm looking at a valvular stenosis. And you apply the same principle to the right side of the heart. So this is an example of aortic override. So you can see that the aorta is not continuous. And then you're left trying to decide, is that just a perimembranous VSD or is that aortic override? In this case here, there's no question. This is not just a perimembranous VSD. This is a very striking aortic override. So this is the anterior wall of the aorta just here. And this is your interventricular septum here. So your aorta is being perfused by both the left and the right ventricle. And in these situations, it's quite dilated. And that's maybe the first feature that you may pick up with tetralogy of Fallot, double outlet right ventricle, or common arterial trunk. So next I want to move to looking at the right ventricular outflow tract. So we look at the right ventricular outflow tract. I want to talk about the importance of looking at the pulmonary artery and understanding the parts of the pulmonary artery. So when you look at the right ventricular outflow tract, you need to understand the pulmonary artery is larger than the aorta and is larger than the SVC. So if we look here, this is the descending aorta, and therefore that's the RV up here. And then I sweep from the right ventricular outflow tract, and I get the continuity of the pulmonary artery, the pulmonary valve with the arterial duct. So that's the first thing that I see. So this is section 1, which is coming out here. The next level in looking at the right ventricular outflow tract is seeing the pulmonary artery dividing into the RPA. And this is the RPA, the aorta, and the SVC. And then the next section, examining the right ventricular outflow tract, is sweeping from the 4-chamber view of heart up to showing both the right and left main pulmonary artery. So these are the various sections you can show in examining a right ventricular outflow tract. You can either just show the RPA, which is this section here. You can show the RPA and the LPA, which is this section here. Or you can show the arterial duct and just the aorta and SVC and not the LP and the RPA. So there are many ways in which you can demonstrate the right ventricular outflow tract. And you need to understand those landmarks. As you sweep, in this case, from a right ventricular outflow tract Up here, we have the aortic valve, the anterior wall continues the ventricular septum, and then we see that this valve does not disappear. So when you look at these semilunar valves during ventricular contraction, they should disappear during ventricular systole. So in this setting, the next step I would move to is looking on my color Doppler to see whether there's turbulent flow. If I see turbulent flow across it, next I'll increase my PRF. If I still see turbulent flow, I'll then move to pulse Doppler. When I look at the pulse Doppler, I wait to hear, so I hear, and then listen to it, it goes, you hear the high frequency. You hear that sound? It changes the frequency. So when you're doing a pulse Doppler, it's very important to move your gate until you hear that sound. Because if you just place it anywhere, you may not catch it. And the point of turbulence will vary along the vessel width. And then I move to the aorta. And you hear the very low frequency sound. And that's the importance of comparing. So this is a pulmonary, this is a pulmonary valve stenosis. So that's important to looking at the right ventricular outflow tract. When you look at the right ventricular outflow tract, the pulmonary artery should cross over the aorta. In this case, you see both great arteries are coming out in parallel. So clearly the spatial arrangement is lost between the great arteries. Next, I want to talk about the next level, which is the three-vessel tracheal view. It's the last level. So in the three-vessel tracheal view, the vessel that's closest to the trachea is the transverse aortic arch. This is the SVC. This is the arterial duct, and this is the main pulmonary artery. And I've got a split image demonstrating laminar flow, red on top. My PRF is at 67 because I'm at 24 weeks of gestation. The advantage of doing a split image is that I'm looking to see whether my settings are correct. Do I have overfill of the vessels of 2D versus, I probably have a little bit overcall there. I could pull back on my gain because my PRF is correct. I do not change my PRF here. I pull back on my gain. If that doesn't pull back on my fill, then I'll turn down my power. And then I look here to a three-vessel tracheal view. I see this is my trachea, my SVC. So straight away I know that that's the transverse aortic arch. And I know that this is the arterial duct, and that's the MPA. So without knowing where the fetus is lying or where the ventricles are, I can straight away say that I'm looking at a narrowing of the transverse aortic arch, number one. Number two, I can say that I'm seeing laminar flow. So this is a coarctation of the aorta, which I'm seeing that there's no evidence of reversal. But when I bring this patient back later on in pregnancy, so when she's 32 weeks of gestation, and if I see that this is red here, I know that I'm getting reversal of flow along the transverse aortic arch. And that's what happens with coarcts, the severe ones. As you track them during pregnancy, you'll see some of these develop reversal of flow. So I know there's going to be a duct-dependent lesion at birth. And then when it comes to coarct...
Echo, aorta, isthmus.
This clip is just showing when you get to that point of seeing that there's narrowing, you go into your menu and use Z-score. So for me, I've just shown you there, I'm taking the measurement on screen. I'll go down to the level of where the isthmus is, and I'll take that measurement. And in most of these ultrasound systems nowadays, you can go straight to calculate your Z-score. If you don't have it in your ultrasound system, then here's your website. And then you calculate your Z-score over time to track whether the transverse aortic arch and isthmus is diminishing in caliber in reference to the pulmonary artery, to get an indication whether it's a true positive or a false positive, because this is one of the concerns with coarct, that we have a very high false positive rate prenatally. I mentioned about reversal of flow, so I'm just going to finish up with these images. So this here is the trachea here, trachea here, SVC. Straight away I can see that I've got reversal of flow. So I know before you even show me the fourth chamber that this fetus has got an obstructed left heart lesion. And I know the most likely reason for that is it has got a hypoplastic left heart syndrome. Thereafter that, critical aortic stenosis, mitral atresia with VSD and so on. I've mentioned them all, coarct. So that's a left heart obstruction. In this one here, I see the trachea is here. If you say to me, Simon, you always talk about seeing the trachea. I can't see the trachea when I go to work. Well, then I'll say, look for the SVC. So if you find the SVC, if you can't see the trachea, you would be able to find the SVC. Then use the SVC as your anchoring point if you struggle with the trachea. But in this case, this is the trachea and the reversal of flow. Oh, it's another, sorry, this is another example of a left heart lesion. So that's a big dilated main pulmonary artery, left heart lesion. And then there's this one. I thought this was the next slide. So here's the trachea and SVC, and here's the transverse aortic arch with laminar flow. In this case, the reversal flow is along the arterial duct. So this is a fetus with a right heart obstructed lesion, with a pulmonary atresia, most likely a pulmonary atresia. To confirm that, you'll need to see whether there's any flow at all across the pulmonary valve. So that's the advantage of looking at the three-vessel tracheal view, is looking for a reversal of flow across either side and determine whether you're duct-dependent lesion. I've gone way over my time, and I think I might stop there and just take any questions. I'll go to Q&A. So just to answer some of the, actually, if I can just summarize, if I go straight to my summarizing slide on this, is the first, in terms of cardiac imaging, one of the key things is having a systematic approach to everything you do. I think you need to know the key landmarks that are laid out in the ISUA guideline. I think you need to look at your 5-section analysis on a day-to-day basis. And I think you need to recognize what the anomalies are and plug in what you expect to see on a section analysis. And with time, you will improve in your detection rate of malformation. Key to success in cardiac imaging is understanding the technical setup with color Doppler. So that's just to summarize that. And then I'll just go to these questions and then take any others if you want. Which is the highest mortality for pregnant women, mitral stenosis or coarctation of the aorta? I don't think I can, first of all, in any situation like that, when counseling a patient about mortality, I'm an obstetrician. I'm not a pediatric cardiologist, and therefore in counseling any patient with cardiac abnormality, I do so with a pediatric cardiologist. So that would be the first comment I make. Secondly, with any of these conditions, there's a very wide spectrum as to how they appear. I'll repeat the question in case some of you haven't heard it, is which has the highest mortality for pregnant women, A, mitral stenosis, or B, coarctation of the aorta? So firstly, it's a pediatric cardiologist who would counsel patients. Secondly, for any condition that presents, there's a wide spectrum of coarctation of the aorta and mitral stenosis with VSD. But if you have the pure mitral stenosis with VSD, that tends to be more a very significant hypoplastic left heart as a general rule. For some of them, you will have a 3-vessel tracheal view where you see a decent size aorta on your 3-vessel tracheal view. With regard to coarctation, I would have to say, for most of these, I'd say it's got a lower mortality because most coarctations that we pick up are mild. And while we see narrowing of the transverse aortic arch, once the duct closes, that aorta the elasticity of the aorta may be fine to accommodate flow in it, and there's no problems whatsoever. And that's in a part the reason why we're such a high false positive rate with coarc. We see these striking cases where there's a narrow transverse arch, but once the duct closes, that aorta perfuses beautifully after birth. So we don't have a looking glass to say which narrowed transverse arch that is going to kink when the duct closes and narrow and pinch off the aorta to produce a problem for the fetus. But even for those, they're amenable for focal coarcs to single surgery. The bad coarcs are the ones that you see in the first trimester, and by the mid-trimester, they have a very significant reduction in the left ventricle. And then you see reversal of flow. Now, for most coarcs who get reversal of flow, they're in the 3rd trimester. But as a general rule, as a very broad brush answer, I would say mitral stenosis would be a much poorer prognosis with VSD, pure mitral stenosis VSD, when compared to coarctation of the aorta. But it's very individual on each case, and it's with a pediatric cardiologist. Next question, what is the best way to position the probe to get the best view of the 4 chambers? I really need a probing hand and a patient to answer that. It's very hard to say, give you the answer in words, but just give you some key clues. The best view is to have the spine at 12 o'clock with the chest anterior sternum at 12 o'clock. 2, in imaging the 4-chamber view of heart, you need to ensure that you have the ribs, a single rib on each side. Frequently, I see people examining the 4-chamber view of heart, and I see that they've got oblique sections to the ribs. And you need to ensure that you have a single rib. But for the rest of that, honestly, how to get a best 4-chamber, I have to have a probe in hand and show you through real scanning. So Kanjang, hopefully one day I can do that in person for you. Reka, what's the significance of a single echocardiac focus in the left ventricle and how to counsel patients about fetal outcome? Well, number 1, I would confirm that it's an intracardiac echogenic focus and not a cardiac rhabdomyoma. That's usually based on size and less so on echotexture. I would confirm that it's in the chordae tendineae, which most are. 2, if it's isolated, most of them are in the left ventricle, 80% in the left ventricle, about 5 to 10% of the right, and then the rest bilateral. If it's isolated and there are no other markers, I would not disclose it to the patient, and I would we don't put it in our report. I make a specific comment that we have a society recommendation not to disclose these to the patient, not to put them in our report. It's called the AAOGU consensus, and I just say it's an Australian consensus of ultrasound specialists, and we do not put that in our report. So I hope that answers your question. We don't offer them genetic testing. We don't offer them NIPT if it's isolated. But remember, folks, every time you see any marker, it's always something to say to yourself, okay, I see a marker. I need to make sure there are no other markers. Don't completely disregard it. So if I see an intracardiac echogenic focus, I look for all the markers of Down syndrome and other chromosome abnormalities. If there are none, I don't disclose, I don't report. Reka has raised her hand.
Yes, Dr. Rekha, you can talk.
Yeah, good evening, doctor, first of all. Actually, what are the markers we need to look into it when a patient comes with an isogenic cardiac focus in the ultrasound report?
Okay, at the mid-trimester is a nuchal fold, nasal bone, prenasal edema, lateral ventricular dilatation, short femur, short humerus, hyperechogenic bowel, renal pelvis dilatation, septal defect, AV canal defect, sandal gap, spinodactyly, missing mid-phalanx of the little finger. And there are all the markers for Down syndrome, about 15 or 20. I may have missed 1 or 2, but they're the main ones.
So mainly we need to look for the markers of Down syndrome.
Yes, I mean, yes. In the world of, yes, you need to look for markers of Down syndrome, number 1. Number 2, you need to exclude, you need to ensure you're not looking at cardiac rhabdomyoma. So some intracardiac echogenic, I have a talk on intracardiac echogenic foci ranging from tiny benign to rhabdomyomas. Sometimes these intracardiac echogenic foci can be of a significant size that you should be worried about cardiac rhabdomyoma. So the first is Downs, the second is cardiac rhabdomyoma, and then the third is other chromosome abnormalities. But you know, for the other chromosome abnormalities, trisomy 13 or 18 that have intracardiac echogenic foci, they have other things that are far more severe than the intracardiac echogenic foci that you will see first. Does that answer your question?
Thank you so much, doctor.
No problem.
Yes, thank you so much.
Not at all, Rekha, you're welcome.
Dr. Tracy, are you there? Dr. Tracy? Please show yourself.
Yes, I am coming on board there. Here we are. And
how are you?
Yes, I am very well. Hello, everybody. Welcome. It is nice and early here in the US. So hello to everybody who is in the evening or 1 o'clock in the morning, apparently, in some parts of the world, which is unfortunate. And I am ready to go with placental pathology. That was an excellent talk, doctor, by the way.
Yeah.
Thanks very much,
we
Tracy.
just go for break for 15 minutes break, and then we will start from your talk. Is it okay for you?
That is fine. I think a break is well deserved after those excellent talks. And Doctor, you stole my thunder for Saturday, but for anybody that had questions about how to obtain some of the views, I will go over that on Saturday if you're able to join us for my fetal heart talk. I will say that's a tough act to follow, but I will do my best.
Tracy, I'm sorry I won't be able to join you, but I wish you all the best with your talk. And
Thank you.
Thank you.
Yes,
Thank you, Dr.
I-
Simon. Really appreciate it. It's 1 a.m. in the morning, I think, in Australia. So I think it's about time for you to sleep.
Yes, I was beginning to mix up my words at the end. So sorry about that. But thank you very much for the invitation, Yassine. It's a pleasure. And to all the registrants, thank you for your patience. It's the first time I've ever had IT problems with this computer, so I'm foxed as to what happened.
Okay. It's fine.
But we got there in the end. My apologies for that.
No, it's all right. Thank you. Thank you, sir. Thank you.
Okay. Good luck to you all. Bye-bye now.
Bye-bye. So doctor, now 15 minutes break. After 15 minutes, we'll start the session again.
Very well. Thank you. Oh, yeah.
Okay. Now you can share your screen, introduce yourself, and then.
Yes. Yes. Welcome, everybody. Thank you all for attending. My name is Tracy Fox, and I have a very brief about me slide. Just to give you my background, I am not a medical physician. I am a sonographer. I graduated from an ultrasound program at Jefferson in 1993, so I've been doing this almost 30 years. I am registered in abdomen, OB-GYN, breast, and vascular. I earned my doctorate in education from Drexel University in 2014. And since 2005, I have been an educator educating at Thomas Jefferson University. I currently hold the rank of associate professor. And in addition to that, I'm a research assistant professor over in the Department of Radiology. I assist with research studies, and I have been doing perinatal ultrasound since, well, pretty much since I graduated. So that is one of my specialties. And what we're going to talk about for this talk is the structure and function of the placenta, its sonographic appearance, and the pathologic processes. The placenta, obviously a very important organ, the life support system of the fetus. And when it goes wrong, it can be deadly to both mom and fetus. So there's a placenta. And how do we examine the placenta with ultrasound? It's very important to scan through the whole placenta. The placenta is an organ like the uterus or the ovary. So as a sonographer, and just as a refresher for those of you not from the United States, in the United States, sonographers do almost all of the scanning with the obstetricians, or in some cases radiologists, to look at the images and or do some scanning as well. But the entire scan is done by sonographers. So as part of our protocol, we look at the fetus, the uterus, the ovaries, but the placenta itself gets its own exam. I scan through the whole organ in 2 planes, sagittal, transverse, and I always evaluate the tip of the placenta to make sure that it is far enough away from the internal os, and we'll talk about that. Also important to check the placental cord insertion, or PCI, and we'll talk about that as well. The placenta has a certain thickness. Does it look thick? If so, measure it, and we'll talk about that. The fetus is only as good as the placenta. If you have a bad placenta, you will have a bad fetus. And in my next talk, I'll talk about fetal growth restriction, and we'll see how a bad placenta can adversely affect the fetus. The placental thickness is typically about 2 to 3 centimeters at 23 weeks and above. It should always be less than 4 centimeters, less than or equal to 4 centimeters. Over 4 centimeters, we consider that to be a thick placenta. There are some conditions where it is expected to have a thick placenta, such as diabetes or anemia, and fetal conditions such as high drops, but it's still abnormal. Typically, after 20 weeks, we can see venous placental lakes and calcifications, and we'll talk briefly about that. Also, there may be fibrin deposits in the intervillous spaces of the placenta. So here's how we measure a placenta. We're going to measure it from the uterus, the inside of the uterus, and also so you can see here the myometrium. So we're going to measure it from the myometrium, or the mucosal layer, if you will, to the edge of the placenta. So a normal placenta, you can see here on the left and on the right, a fetus with hydrops and a markedly thickened placenta. Placental lakes are completely normal. These are the anechoic areas or hypoechoic areas that we can see within the cotyledons of the placenta. And on color and color Doppler, they may appear to have flow. And even on grayscale, you can see swirling within them. So here are some more examples. Here's one right below this layer of the placenta here. You can see right below the surface of the placenta. Here's some more examples. Notice nothing lights up even with power Doppler. This is very, very slow flow. When we describe the placenta, we need to describe its location: anterior, posterior, fundal, right or left lateral. Sometimes it's a combination, posterior, fundal, for example. That distinction becomes important because sometimes if a placenta is posterior fundal, for example, we know there's not going to be a previa. We know if the placenta is anterior, there's a greater chance, especially if it's anterior low, there's a greater chance that there could be a morbidly adherent placenta. So it's important to describe the location. Focal uterine contractions, like you see here where the myometrium balls up, may make the placenta appear to be either a previa, because it can shift its location, or even a placental mass like a chorioangioma. Ignore them. Go back, and I mean, you can put color Doppler on and see that it's a focal uterine contraction, but could also mimic a fibroid, but get off of it. Go back, do the rest of your scan, and then come back to it. If it's a contraction, it's gone. Let's look at the different types of placentas and cord insertions. The typical, normal, everybody's happy placental cord insertion is the central insertion, where the cord inserts into the center of the placenta. It's not necessary to use color Doppler, but we frequently do use color Doppler just to show the PCI. I always document it on my anatomy scans because the clinician wants to know that it's not one of these other types. The battledore or marginal insertion is where the cord inserts on the edge of the placenta. You can see the pathologic specimen on the left, and you can see the ultrasound image there. There's a low incidence of clinical significance, but again, we do document it. And then the most dangerous type is the velamentous, which is a membranous insertion. So this is where the umbilical cord inserts into a membrane, and then these vessels connect to the body or bulk of the placenta. This is okay as long as that membrane does not cross the internal os. If it crosses the internal os, this is a condition called vasoprevia, which I'll cover in more detail shortly. And this can lead to fetal death and even maternal death from hemorrhage. So let's look at vasoprevia. This is when fetal vessels or membranous membranes with vessels cross the internal os of the cervix. Occurs in about 1 out of 2,500 deliveries. Again, this can lead to death. The most common causes are the velamentous cord insertion and the succenturiate lobe. So when you have a patient that has either a very low placenta or a succenturiate lobe, or that's not all the way up in the fundus or something like that, if it's somewhere near the lower part of the uterus, or if you see a marginal cord insertion, it's very, very important to make sure you put color Doppler over the internal os. And you can do this transabdominally. Usually you'd still be able to see it. If there's any question whatsoever, you must do a transvaginal ultrasound because of the risk of death. So one of the things we're looking for, so for example, what if you don't see the placental cord insertion into the meat of the placenta? Well, it may be a membranous insertion. And if that's the case and you're not sure where that cord inserts into that placenta, you have to do color Doppler. And here's a transvaginal ultrasound. You can do transperineal ultrasound as well, showing fetal vessels crossing in between the head and the internal os. This is missed. This is something that is not always caught, and to devastating consequences. So here's another example showing a membranous insertion. Here's another example of a membranous insertion. However, this one is up in the fundus. It's not as concerning, but there are umbilical cord insertion is here, and then there's fetal vessels, and then here's the meat of the placenta. And again, you can see the pathology specimen similar there. So if it's not crossing the internal os, it's not as much a concern, but we have to make sure. Here's another example showing filamentous cord insertion with vasa previa. Again, notice color Doppler. One thing is to make sure it's not flash artifacts. So for example, if you use power Doppler and the baby is moving around, causing the fluid to move around, that will cause a Doppler shift. So make sure, wait until the baby stops moving. Color Doppler may still have flash artifact, but it's less sensitive. But power Doppler, you'll have pixels light up from any motion. So make sure the baby's not moving. Here's another example. This patient actually has an incompetent cervix or a partially open cervix and vessels crossing. This is an emergency situation. And just one more example here showing the cord inserting marginally or velamentous. The succenturiate lobe is an accessory lobe of the placenta. So the bulk of the placenta is in one location, in this case posterior, and then there's another little lobe there. The importance for the clinician is because when the placenta is delivered, it's nice that they know there's another piece in there to make sure they get it so that it's not retained. So if you suspect a succenturiate lobe and you're not the delivering physician, it's always a good idea to mention that. But you can see where the problem would lie. If you have a succenturiate lobe and the bulk of the placenta in another location, there's a membrane with vessels that may cross the internal os. And here you can see a succenturiate lobe and placenta, and there are membranes connecting the two that in this case are crossing over the internal os. Again, this is a very important thing to mention. And again, I mentioned the risk for retained placenta. So here's an example of a delivery of a placenta with a succenturiate lobe, and you can see an example here. These are very common, and rarely do they cross the internal os, as I'm showing you. But again, since vasa previa is so underdiagnosed and so potentially lethal, it's always good to make sure it's documented. Here's another example showing the membrane crossing between the two. And then something called extracorporeal placentation, in this case, the circummarginate placenta. This is nothing. This is abnormal attachment of the fetal membranes right at the fetal surface where the chorionic plate is smaller than the basal plate. And you can see it here, but notice there's no rolled edge. The edge is flat. It's not diagnosed with ultrasound. It's a pathology diagnosis. And the good news is it's not associated with fetal problems. The circumvallate placenta, on the other hand, is where you have a rolled edge because the membranes are folding in. And there's this characteristic rolled edge. This is frequently underdiagnosed as well, but you can see this on ultrasound, this rolled edge. The potential risks are bleeding, growth restriction, premature rupture of membranes, and fetal abruption. But again, frequently underdiagnosed. Here's another example showing a rolled edge. Placenta previa. Placenta previa is another thing that can lead to fetal demise if not diagnosed. Fortunately, with frequent use of ultrasound, placenta previa is very frequently diagnosed as long as ultrasound is available. And it occurs very commonly. But what is a previa, what isn't, and who has a previa at delivery is a whole different story. Placenta previa has 3 flavors, and some people use more categories, but there's 3 essential types. There's placenta previa, which is where the placenta is covering the internal os. The low-lying placenta previa is less than 2 centimeters, and I'm going to clarify that in a second. So less than 20 millimeters of the placental tip from the internal os, and normal is anything over 20 millimeters. Anyone with previa is considered to be a high-risk pregnancy. So the standard definition is greater than 20 millimeters, but I will say that some centers use less than 10 as previa and over 10 is normal, and that's based on their experience where they have done labor in people with between 10 and 20 millimeters away from the internal os and not had adverse effects. But that's up to you and your institution. So notice I don't have in here marginal and partial and all that. So a lot of that stuff gets in the weeds. The internal os is a point. It's not a big area. And so the placenta is either covering it or it's not covering it. And so if it's normal, it's normal. If it's previa, it's previa, although it may not stay that way. And if it's low lying, it gets a follow-up. So here's an example of a placenta completely covering the internal os. Now it's gestational age dependent. Do not call a placenta previa at 12 weeks or even 15 weeks. Wait till they come back for their 20-week ultrasound and then see if the uterus has grown enough for it to move away from the internal os. And even if you see a previa at 20, 22 weeks, you scan them again later in the pregnancy, it may have moved far enough away. But it is safe to do endovaginal ultrasound to confirm a previa or rule it out. You're going to use color Doppler with that. Do not scan with a full bladder. For some reason, there are still labs out there, usually radiology labs, not maternal medicine labs, that are scanning with full bladders, and everybody has a previa. You must do it with an empty bladder or transvaginal. And with a previa, the patient may be completely asymptomatic or the patient may have bleeding. The low-lying placenta, in a study done by Heller in 2014, 90% resolved by 32 weeks and 96% were resolved by 36 weeks. So here you can see an example of a low-lying placenta. Here's the tip, here's the internal os, it's 14 millimeters away. In some labs, this is still, it's going to be treated like a previa. The patient gets a C-section. In some labs, they'll do a labor, induced labor, or have the patient go into labor. Here's a pathology specimen of a previa, so this probably didn't have a good outcome, I'm guessing. And then here's MR. MR is very useful in trying to figure out if ultrasound can't quite seem to make the diagnosis, MR may be used. And here's a transvaginal ultrasound showing a complete previa. Again, here's the internal os right here, and this is placenta covering it. Here's a low-lying placenta. It's not quite covering the internal os. However, it's a very, certainly less than 10 millimeter margin. Unless this patient is in the third trimester, this is getting follow-ups through the third trimester. And we can do this right up until delivery too, do a transvag ultrasound. And again, the transvaginal ultrasound's very beneficial because remember, even if the placental tip stops before the internal os, there may be membranes that go across, and that's a vasoprevia, and we already talked about the seriousness of that. Here's a great example of so-called placental migration. Remember, the placenta doesn't move. In and of itself, it's fixed to the uterine wall, so it doesn't move. But as the uterus grows, it may pull away the placenta from the internal os. So here's an example of a very low-lying placenta, or some would say previa, at 23 weeks, and then at 28 weeks, it was 18.5 millimeters away. So what might it be at 36 weeks? Probably greater than 20. Either way, the patient's getting a follow-up, but either way, this patient probably can go into vaginal labor. Morbidly adherent placenta is another way the placenta can be dangerous for the patient and for the fetus. And this is more commonly called accreta. Ultrasound does not have the ability to distinguish for sure between accreta, increta, and percreta. These are the three types of morbidly adherent placenta. Again, collectively commonly called accreta. However, when we say accreta, we're not really sure exactly what type it is, although sometimes we can help guess, but these are pathological classifications. Accreta is the least invasive form. The villi do not invade the myometrium. This is when the obstetrician goes to deliver and the placenta is tough to come out, but it does come out. Increta is when the villi penetrate the myometrium, but not through the serosal layer. And percreta, per means through. Percreta is when not only do the villi penetrate the myometrium and serosa, they also may invade the bladder and other organs. So, for example, I've had patients with percreta, they do a cystoscopy, and they can actually see placental vessels inside the urinary bladder. The risk factors are previa, especially if that patient either had a C-section, which means they have part of their uterine wall that's thinned, or any other uterine surgery, and advanced maternal age. The thing with previa, if you have a patient that has an anterior placenta and previa, or an anterior placenta with a history of C-section, I instantly suspect accreta until I can convince myself it's not there. So any history of C-section with or without previa, but an anterior placenta, I'm instantly concerned. So if the placenta cannot become detached, it can lead to massive hemorrhaging and death, especially with the more invasive forms. And again, if percreta is suspected, if you see some what looks like invasive vessels, and I'll show you some images, the cystoscopy must be done. So for the diagnosis, this is sometimes when you may want to look with a full bladder first and then an empty bladder if you have an anterior placenta with suspected accreta. You want to check the myometrium thickness. Even a patient in the 3rd trimester should have some myometrium. It'll be thin, but it should be there. Don't be afraid to do either endovaginal or translabial scanning. One of the hallmarks, and I can see this in the 1st trimester, is prominent vascular lacuna at the invasion site. And these look like big cystic areas in the lower uterine segment, and they instantly not only raise my suspicion for accreta, but I'm already convinced there isn't accreta until proven otherwise. And as soon as I see them, the next thing I do is I ask the patient, have you ever had a C-section? And a lot of times they say yes, and I know what it is. And color Doppler at that placental myometrium border can also be helpful. And this drawing is helpful to show a normal placenta versus an accreta, increta, and percreta. And you can see that complete penetration through the serosal layer. So here's a nice example of a normal myometrium. This is obviously an early pregnancy, but you can see this beautiful, this is the bladder wall here, and then this is this hypoechoic myometrium, and here's this anterior placenta. The reason why you may want to scan through a full bladder if you're suspicious of accreta is because you can get this nice specular reflector from the bladder wall and showing that myometrium there, and it can also help with color Doppler. But if you don't have a full bladder, you can also still usually see whether or not there's a myometrium present. But having this closer to 90 degrees versus 0 degrees can be helpful from a physics standpoint. Here again with a full bladder, you can see there's color Doppler all the way to the edge. There's no myometrium here. So this is most likely an accreta of some type, so morbidly adherent placenta, if you will. And then here you can see these vascular lacuna in the lower uterine segment. And again, this is always concerning to me for accreta. Here's another example. These prominent vascular spaces, very concerning for any type of accreta. Here with color Doppler, you can see they light up almost like varicosities. So these are retroplacental vascular spaces. So this particular patient has a history of C-section. In my book, she has a morbidly adherent placenta or some type of accreta till proven otherwise. And it's really important to know because these patients can have massive hemorrhaging during delivery and possibly not be able to stop it. We had one patient who received, I think it was 20 units of blood, and they eventually had to get her to the interventional suite and put coils in her uterine arteries to stop her from hemorrhaging out. We've had patients go into DIC from having an accreta that was underdiagnosed or not diagnosed. Here's another example showing large blood vessels with no appreciable myometrium. And then this is invasion of the placenta, of the myometrium. Here's an MR, again, showing these vascular lacuna spaces. and same thing here. So you see how you get a much more heterogeneous, I don't want to call it holy, but cystic placenta, or just in the lower uterine segment, these big cystic areas. Here's a pathology specimen showing the placenta invading the myometrium. And then here is at the C-section, blood vessels coming through the uterine wall. So you can see these vessels here, and these are placental vessels. Here's a great image showing a hypervascular placenta because of those vascular spaces, and again, no appreciable myometrium and vessels all the way out to the edge. Here you can see invasion through the bladder wall. And here, again, just a whole lot of blood flow, much more than we see with a normal placenta. And just a reminder, you can see that in the first trimester. So if you see that, anything that looks like that in the first trimester, be prepared to do a follow-up on that. Placental abruption is yet another thing that can kill mom and the fetus, and is the leading cause of perinatal mortality. And part of the problem is ultrasound's complete inability to be able to diagnose this. Not complete inability, but we're not very good at it. If the placenta detaches and mom or the fetus do not die from hemorrhaging, it can lead to growth restriction if enough of the placenta detaches. So now it becomes a growth restriction issue. But it accounts for about 15 to 20% of perinatal mortality. The symptoms are bleeding, pain, shock, and preterm labor. And the risk factors are any history of previous abruption. Mom might not have a very good uterus, and the placenta doesn't like to stay attached. Any kind of trauma, fibroids, smoking, and advanced maternal age. Now with trauma, if I have a patient who is in a trauma, like a car accident, and has bleeding and is pregnant, it's an abruption until proven otherwise in my book. And I'm going to do what I can to try and rule it in or rule it out. And I acknowledge ultrasounds not being great at diagnosing it, but we can see it. So you have to at least look for it. Clinical presentation, the patient may completely asymptomatic, or the patient may expire, or the fetus may expire. Again, the patient may have vaginal bleeding. Backache is also another one, or abdominal pain. Fetal well-being needs to be looked at. So on a non-stress test, there may be variables or late D cells, bradycardia. And if more than 50% of the placenta has pulled away, fetal death is likely. Or you have to do an immediate emergent delivery, depending on the gestational age. And then again, the patient's at risk for disseminated intravascular coagulation, DIC, or hypovolemic shock. Retroplacental abruption is very dangerous because it looks totally normal on ultrasound. It may just look like a thickened placenta. And sometimes you can see it because you might see the placenta kind of looking like there's a focal uterine contraction or something behind it, but go with the history. If the patient was in some kind of trauma and now has bleeding, and you see what looks like something behind the placenta, be aware it might be retroplacental hemorrhage. Put color Doppler or power Doppler on it. The marginal abruption is on the edge of the placenta. This can look like a hematoma hanging off the edge. We're better able to see this. And fortunately, it's the most common form. And again, this will cause vaginal bleeding usually. So here are the most common locations: retroplacental hematoma and marginal, we already talked about. And then there's a couple other locations where it can occur. Here's a retroplacental hematoma. This looks like myometrium to me. So this is why we say it's the most dangerous type, because it's frequently missed. Here's another example where it's just this little bit, just lifting up. This is a marginal one. It's just lifting up the edge. But you can see, especially with good technical settings, where that might be easier to see. So we have low sensitivity, but good specificity for abruption. This is another area, by the way, Dr. Simon had mentioned about using the linear transducer, and the higher frequency linear transducer, again, can offer better resolution, especially superficially. If you're looking at an anterior placenta, it might not be so helpful on a patient that's farther along or posteriorly, but don't discount the linear transducer for improved resolution in some things. Here's an example of a 36-week retroplacental abruption. and 37 weeks. Now, one of the things is it can be very heterogeneous, right? So especially when clot's been sitting there for a while, it becomes heterogeneous. So it may not even be normal placenta you're looking at, but abruption. And then here's a subchorionic plate placental hematoma. Again, these aren't so easy to pick up, especially further along in the pregnancy, but keep an eye out for areas of decreased echogenicity. And then the chorioangioma. That is the most common benign placental tumor. It's from chorionic tissue. The only problem is if they're large, it may cause fetal high drops because it overloads the heart. And so you get fetal cardiomegaly, growth restriction, preterm labor, and preeclampsia. And they're very vascular. So color or power Doppler, they should really light up and you'll know what they are. They are not fibroids. They are not focal uterine contractions. Neither one of those, well, focal uterine contractions go away. Fibroids will not have the color flow of a chorioangioma. And then here's a pathology specimen, and here's some more power Doppler and grayscale examples. Notice that there's maybe some calcifications there. These are usually well circumscribed. Here's another example. This is a chorioangioma, and again, doesn't look like much of anything, but then when you put the color Doppler on, it lights up. Thrombosis and fibrin deposits. Intervillous thrombosis is an intraplacental hemorrhage. It looks like a lake, but you will not see any flow in there, either in grayscale or color Doppler. And fibrin deposits are completely insignificant. They're very common. These are just hypoechoic lesions within the placenta. Placentamegaly, we mentioned in the beginning, is greater than 4 centimeter placenta. Usually it's a homogeneous placenta, depending on how far along the patient is and how calcified the placenta is. Common causes are maternal diabetes and fetal high drops, so gestational diabetes especially. If the placenta is heterogeneous in appearance, the more likely etiologies are triploidy, hemorrhage, and Beckwith-Wiedemann syndrome. Premature placental calcifications. We used to make a big deal back when I started ultrasound almost 30 years ago. We made a big deal about grade 1, grade 2, grade 3. We don't even report it anymore. The important thing is if you have a 20-week fetus with a calcified placenta, you have a bad placenta, and this fetus is going to have growth restriction or has something else going on, possibly aneuploidy or something. So you don't, it's not so much important how much calcification the placenta has, it's when does it have it. So if you have a patient in the early second trimester with placental calcifications, does mom have hypertension? Is there fetal growth restriction? And if not, there probably will be. Does mom have preeclampsia, and is she a cigarette smoker, which can also cause early placental calcification, although not even to this extent. Triploidy is also called a partial mole, and the fetus has 3 times the number of chromosomes. This is uniformly lethal, but it affects the placenta in that the placenta has cystic spaces. So here you can see a very thick placenta with cystic spaces. And again, another example. And this is a non-viable pregnancy. Another example. And then infection. CMV is the most common congenital infection. It can be associated with decreased mental function and other defects. The fetus may have ascites, dilated ventricles in the brain, growth restriction, and calcifications in the brain, but it can affect the placenta before it affects the fetus. So again, when you see a thickened placenta, maternal infection should be one of the causes or things to look for. Fetal high drops, regardless of the cause, immune versus non-immune, either one can cause a thickened placenta because it also causes thickened skin around the fetus, fetal edema. It can also cause effusion. So you can see this fetus here has ascites in the abdominal cavity, polyhydramnios, excess fluid. So regardless of the cause of high drops, which can also be associated with heart failure, notice the pleural effusion you see here. It could cause placentamegaly. And here a picture that I took when I was fortunate enough to be in Dubai for this course a few years ago. Beautiful country, looking forward to eventually getting back, but I will tell you this is the next best thing. I'm happy to answer questions before I go on to my next talk.
There is no question.
One just popped up. The significance of placental lakes, none.
Yeah.
There is no significance. You just want to make sure it's a lake and not something like a lacuna, like you would see with a morbidly adherent placenta. And
Dr. Rekha wants to.
Hello, doctor. What is the, like, if a patient comes with the placentomegaly with IUGR, like what we can suspect, doctor? IUGR baby.
Most commonly with IUGR, the placenta will be thin, but since a thickened placenta can be associated with things like triploidy and things like that, you want to look and see if there is growth restriction, and especially if it's early growth restriction, is it from an aneuploidy or something along those lines. But when it's a late, especially a late growth restriction, and we're leading into my next talk, which is perfect, I appreciate that, then it's more likely to be a thin calcified placenta because the placenta is no good, usually in late growth restriction. But in early growth restriction, and if you had placentomegaly, I would worry about aneuploidy.
Aneuploidy in the sense means a double marker test was done for the patient. It was normal.
I see. So normal with a thick placenta, I might worry about diabetes because you can have diabetes and growth restriction.
That's also normal, doctor. We have screened that patient as well.
Okay.
No diabetes. No diabetes.
No diabetes, thick placenta, and you have normal chromosomes.
Okay, so you mean like amniocentesis has to be done?
Oh, so you don't have chromosomes. So one option would be to do, well, how thick was the placenta?
8 centimeters.
Wow.
At 20 weeks. At 20 weeks. And the baby parameters are around 17 weeks, 5 days.
Yeah, I'd have immediate concern for some kind of aneuploidy unless there was any other cause to have it. I'm just going back to my list here, but because anemia would be another one, fetal anemia. So you want to make sure there's no high drops. But with IUGR, did you do an echo, fetal echo?
No, doctor, fetal echo was not done. Actually, it should be done at 22 to 24 weeks, right, doctor? So we are planning that.
Yeah. Right. Yeah. 22 weeks, I would do the fetal echo. And I would make sure that there's no other markers in the fetus, but you know, I'd let any of the obstetricians chime in to see if they have anything else, but aneuploidy and something with the heart are the only things I can think of off the top of my head.
Any infection screening has to be done, doctor, for her? CMV was the thing you have shown. Placentomegaly is also.
I would run a torch panel.
Okay.
We had a patient one time that actually wasn't our patient. I was asked to do a legal review. I do expert witness work. You know, in the United States, we love lawsuits. And so I get asked to review cases for legal review. And there was a case where a patient had twins and the fetus had, the one had IUGR. Both babies were born, one dead and the other one very, very, very sick with severe neurological deficits, and it ended up being CMV. Okay. But now I'll have to go back and look at the placenta, but maternal infection is definitely a cause for concern. The only thing is you have to get titers on mom, but that's another thing where, you know, you might need to do an amnio to look at the, to look for that, but definitely to do the blood work on mom.
Okay, one more doubt, doctor. Even though if CMV was detected at this gestational age, like how we can benefit the mother?
You don't. There's no treatment. There's no effective treatment, but you can at least depending on where you are and the patient, termination of pregnancy might be an option in some cases, otherwise counseling. And there are some things, there is stuff in the literature that people have tried, but there's no known effective treatment.
Yes. Thank you so much, doctor.
Oh, you're welcome. Thank you for your excellent question.
Dr. Sumedha Wagmore. Yes, you need to unmute yourself and you can ask the question. Dr. Wagman.
Hello. Yeah. Yes, ma'am. I want to ask you that how much volume of the placenta visibly needs to be showing calcification at 21 weeks to call it as abnormal?
That's a great question. That's subjective. There's no quantitative value for that. It's the imager's eye. So in other
How
words,
much percentage approximately? How much approximately like that?
I don't even have a number to give you. It could be scattered calcifications. If I see any calcifications at 20 weeks, to me, it's abnormal. I should not see calcifications at 20 weeks. The patient is probably a smoker, in which case it may mean nothing, but it could precipitate fetal growth restriction. It might be an early warning sign for growth restriction. But if I see any calcifications at 20 weeks, I'm not happy.
Okay.
And I will tell you, 9 times out of 10, when I see placenta calcification at 20 weeks, even just a little bit, I ask the patient, and I would say 99 times out of 100, I ask them if they're a smoker, and they say yes.
Okay. Thank you.
You're welcome. And then I see a couple more questions. How to differentiate lake and lacuna. The lacuna that we see with morbidly adherent placenta, they're always in the lower uterine segment. So these are always low-lying or previa, or an anterior placenta that's a previa. And they're big. They're huge vascular spaces that light up with color Doppler. Lakes don't light up with color Doppler. There's swirling flow that you can see with your eyeball, but they are too slow for a color Doppler. So if it's a lake, if you see a hypoechoic area in the placenta, and you see some swirling flow with the naked eye, it's a lake, and it's of no clinical significance. If you see something in the lower uterine segment with a low placenta and it looks like a hypervascular space, it's probably a lacuna and needs further investigation. It doesn't guarantee morbidly adherent placenta, but it's a warning sign, and you have to further interrogate it. And then someone asked the grading system for placental maturity. There's grade 1, 2, 3. Grade 1, scatter calcifications. Grade 2, some indenting of the surface of the placenta. And grade 3 with the cotyledons. But I will tell you, we don't use it anymore. We don't even report out placental maturity. But if you see a completely divided placenta, meaning visible cotyledons in the placenta at 20 weeks, it doesn't matter if it's a grade 2, grade 3, it's really abnormal. So, but if back in the old days, as I like to say, we used to think that placental maturity had to do with lung maturity. We now know they have nothing to do with it. So because placental maturity doesn't really affect anything, we don't do the grading anymore when we report out. Like I said, in our report, it won't even say grade 1 or grade 2 placenta. So you can go into the textbooks and look at the images. I took it out of this lecture. I used to have it in here, but we don't report it anymore, so I took it out. I'm just going to stop my share so I can get to my next lecture. But again, happy to answer any additional questions. I think that's it.
That's it.
Okay, let's bring up the next one. And actually what I'll do, let me do this. Let's close out this one. Okay. This next talk, and again, that was a perfect segue, is on biometry and fetal growth restriction. And the real good news is this talk probably will not take 40 minutes, so we may actually get done on time today, which is fine. But again, I can stay as long as needed to answer any questions. So we're going to talk about how to measure the fetus, and we'll talk about fetal growth restriction, which is intrauterine growth restriction. So we're going to talk about the biometric parameters, describe the anatomic landmarks, which are absolutely critical, and talk about fetal growth abnormalities. Many of the standards I list, because I'm in the United States, are based on ACOG recommendations and/or AIUM recommendations, but I did put some of the ISUOG recommendations in here. There's some overlap. It's not complete overlap. Definitions. Full term is between 39 and 0/7 and 40 and 6/7 weeks. before 37 weeks is considered preterm, with 37 to 38 and 6/7 being early term. And the reason why they separated this out years ago is because of the higher rate of mortality. So that's why they did that. Late preterm is 34 to 36 weeks, and early preterm is less than 34. In the United States, the definition of legal viability is determined by state law. In the case of Pennsylvania, where my institution is located, viability is defined at 24 weeks. The leading cause of death in the neonate, less than 28 days old, is preterm delivery and is responsible for 27% of deaths worldwide. This is a problem. It's a huge problem in the United States. We have one of the worst rates of neonatal mortality in the world. Dating the pregnancy. So up to 13 and 6/7 weeks, use the crown rump length. And this is an ACOG recommendation. And I will tell you that some people will do a BPD, HC, and femur length at 13 plus weeks. And because I used to do it all the time, and that's fine, but they do recommend the crown rump length before 14 weeks. If there's an assisted reproductive technology pregnancy, use the gestational age. Since we know an implantation occurred, use that gestational age. If the first ultrasound, since we know LMP is notoriously unreliable, and the most accurate way to date the pregnancy is by first trimester scan with a crown rump length. If the first ultrasound is within 5 to 7 days, assuming it's a first trimester dating scan, or if it's within 14 days after the first trimester, meaning in the second trimester specifically, then use the LMP. So in other words, if you do a first trimester scan and it's 3 days off from the LMP, don't change the date, keep the LMP as establishing the estimated due date or estimated date of confinement, whichever you prefer. If it's a second trimester scan, if they come in for their first scan at 20 weeks, and your dates are within 2 weeks of the LMP, keep the LMP. Now, you might have to get a follow-up in this case to make sure there's not an IUGR in progress or an FGR in progress. If it's a first trimester ultrasound and it's greater than a week off, change the date. You still want to make sure, you got to get a follow-up, make sure it's not an aneuploidy and that's why it was small. But if it's a first trimester ultrasound more than a week off, you have to change the date. The patient has a new due date. Because again, LMPs are notoriously unreliable. If it's a second or third trimester, if the patient shows up at 30 weeks for the first scan and your dates are more than 2 weeks off, you can change the date, but you have to get a follow-up in 3 weeks to make sure that these incorrect due dates are just that, incorrect dates, and not pathologic. Because maybe her LMP was right, but there's aneuploidy. So in this case, when it's a late first scan, consider the due date suboptimal. Kind of put an asterisk there. The primary measurements for measuring the fetus is the BPD. This is out of the first trimester, second and third trimester, the biparietal diameter, the head circumference, abdomen circumference, and femur length. Other additional measurements we routinely get is the phallic index, which comes up automatically, the OFD, which may come up automatically depending on the machine you're using, and the transcerebellar diameter, which is a measurement of the cerebellum. Then the AIUM practice parameters offer information for a standard ultrasound and then additional images that are required for what's called a detailed ultrasound. So you might just be doing like a growth scan, in which case you would just do the standard parameters. Or if you were doing an anatomy scan, which is usually that 20-week scan, you would add additional things to it. The ISUA guidelines on quality control. So quality control is important and often overlooked. I go to many ultrasound centers as part of my day job, and I don't see enough quality control. What is quality control? An independent person to look at the images that people are taking and seeing if they're doing it right. If you're not putting the calipers in the right spot on every case, I mean, sometimes there's technical limitations, the baby's head is in a tough position or something, but you might end up having more lawsuits, at least in the US, than you would like to have if you don't have somebody independently reviewing these images and doing retraining if needed. Measurements should have good interoperator reliability or reproducibility. In other words, if I do a biometric study on a fetus, you should be able to come in after me and get numbers that are within a day or two, keeping in mind that there's always going to be some degree of difference within a millimeter or so of caliper placement, but it should be reproducible. The did I miss one? No, the cephalic index, as I mentioned before, is needed to offer a corrected BPD. And that's because sometimes the BPD is unreliable. If the baby has a very skinny head, dolichocephaly, or a fat head, brachycephaly, a wide head, then the BPD will not be reliable. You might have a BPD that says 22 weeks and a head circumference that says 20, and then your dates are going to be off. So if the cephalic index, which is the BPD divided by the occipital frontal diameter times 100, this is calculated by the machine. The cephalic index is less than 75 or greater than 95. That defines these two things. And again, the OFD is independent of head shape. And this is how we get, the corrected BPD is independent of head shape. It's the BPD times the OFD divided by 1.265, and that's a corrected BPD. So in a fetus with dolichocephaly or brachycephaly, use the corrected BPD when determining your estimated fetal weight. So what are the landmarks for the biparietal diameter? You want a perfectly cross-section, horizontal cross-section of the head. And where, first of all, how do you know it's perfectly horizontal? Do I see any eyeballs? No. Do I see any posterior fossa, cerebellum, cisterna magna? No. That's a good start. Am I symmetric from this half of the brain to this half of the brain? Yes, I'm not oblique. So now I know that at least I'm in the correct plane. Now, how do I know I'm at the correct location? I need to see the thalamus with the third ventricle in between, the cavum septum pellucidum that looks like a box with no line in it, and I need to see the symmetrical falx, and you will see the choroid plexus or lateral ventricles laterally. The head and the BPD measurement, you want to imagine, this is where the sonographer's vision comes in. We do an imaginary line that bisects the head, and we go from outer parietal bone to inner parietal bone. And you want to be perpendicular to the falx. This line should be perpendicular to the falx, outer to inner. The head circumference, we're going to put our caliper in the same spot for outer, only now instead of inner, this caliper will go outer. So the head circumference, same landmarks as BPD, but it's outer to outer parietal bone, and you're going to use the ellipse tool to open up the ellipse and get the head circumference. So BPD, outer to inner, must have thalamus. Here's an ultrasound image showing the thalamus, the cavum septum pellucidum or pellucidae, it's technically plural, the falx cerebri, not well seen here, you can see a piece here, and it needs to be symmetrical left to right, no posterior fossa, no eyeballs. And then you can see the plane here. The head circumference again is outer to outer. Outer to outer. You're going to use the ellipse. First caliper is going to stay in the same spot. The second caliper is going to go outer instead of inner. Caution, do not include the fetal skin. We're not interested in the skin, just the parietal bone. The cephalic index is going to be calculated for you automatically. If the head is brachycephalic, like you see here, or dolichocephalic here, your BPD will have measurement error. Another thing that can give you measurement error is a breech presentation or oligohydramnios. Here is a nice example showing BPD and head circumference on a beautiful fetus. And yes, you can get them all in the same image. Notice the cephalic index is automatically calculated. And again, if a corrected BPD is needed, the formula is right here. Other anatomy that we routinely get is the posterior fossa. And I'm not going to go into a whole anatomy study. It's outside the scope of this talk. But as part of biometry, you may need to do a transcerebellar diameter. And then the cisterna magna is right there, so we'll talk about that. That normally would be less than 10. And then the nuchal fold is right here, and that should be less than 6, or in some labs, they say less than 5. So the cerebellum, cisterna magna, nuchal fold can all be measured on the same image, which is why I'm throwing them all in together. The cerebellar diameter should be equal to the number of weeks of the fetus, less than 22 weeks. So up to about 22 weeks, that cerebellum tells you the gestational age of the fetus, if it's normal. So an 18 millimeter cerebellum is an 18-week fetus. A 20 millimeter cerebellum is a 20-week fetus. If you have a 20-week fetus with an 18 millimeter cerebellum, there may be something like Down syndrome going on. So you want to look into the other markers. And the cisterna magna should be less than 10. And the nuchal fold should be less than 6 millimeters. Again, some labs say less than 5, and that's only valid up to 21 weeks. So after 21 weeks, we don't measure the nuchal fold. So again, here's another image of the nuchal fold. This one is less than 6 millimeters, and this one is greater than 6 millimeters, and in fact is abnormal. Not recommended or not required by the AIUM anymore as part of routine measurements on an anatomy scan, but something you still may need to do if you suspect pathology is the biorbital diameter or the interorbital diameter. So the outside to outside and inside to inside diameters. Again, they're not required as part of an anatomy scan, but if you suspect, as the good doctor mentioned in his first talk, if you suspect something like holoprosencephaly or something like that, you may need these additional measurements. The atrium of the lateral ventricles, we always measure. They should be less than 10 millimeters. Again, here's the cavum septum pellucidum that we expect to see when measuring a BPD. And again, remember that it needs to look like a box. There should not be a line in there or you're at the wrong spot. One thing I'll mention, this is a trick I give to my students. If you can't remember what the normal size of something is, and somebody asks you, what is the normal size for this body part? Just say 10, usually 10 millimeters. 50% of the time you'll be wrong, but 50% of the time you'll be right. So for example, for cisterna magna, it's less than 10. Atrium of the lateral ventricle, it's less than 10. Renal pelvis measurements, less than 10, right? But again, 50% of the time you'll be wrong. So nuchal fold, less than 6, but just a rough guideline. So remember I said the cavum septum pellucidum should look like a box, and that's what we mean right here. If you see the line in there, you're at the columns of fornix, you're at the wrong level. And in fact, this right here is the cerebral peduncles. That's the brain stem. You're too low. The thalamus is much harder to see. It's heart-shaped and it's bigger and it blends in more. The peduncles are much easier to see and frequently in BPDs that are measured wrong. The abdomen, the abdominal circumference is another important measurement. So for one thing, it's important that you are true transverse and not oblique. How do you know if you're true transverse? The spine should look like 3 dots and you should only see 1 rib at a time. If you can see 3 ribs or more than 1 vertebrae at a time, you are oblique. The umbilical portion of the portal vein should be free floating within the abdomen. This is sometimes called the hockey stick sign because it doesn't look at all like a hockey stick, but that's what we call it. The hockey stick sign shows a free floating piece of the umbilical portion of the portal vein in the abdomen. And of course, we should see the stomach. If you can't see the stomach, you can still measure the abdominal circumference, but you need to come back and make sure the stomach fills at some point during the exam. Another thing is you should not see any kidneys. It's okay to see adrenal glands, but you should not see any kidneys and you should not see any part of the fetal chest, no heart, no lungs. So stomach, hockey stick, spine and cross section. Here's an adrenal gland, that's fine. And we measure the ellipse. Now, when we measure the abdominal circumference, you must include the fat around the abdomen. At 20 weeks, there's not a lot of fat. So this is an adequate abdominal circumference. This is a beautiful image. There's not a lot of fat. When they get to be in the late 2nd trimester and in the 3rd trimester, and especially if they're a diabetic, you must include that fat. No heart, no lungs, no kidneys. Here's an example of an incorrect location. Yes, we have a stomach. No, I don't see the kidneys, but we're oblique. I can see the umbilical portion of the portal vein touching the anterior abdominal wall. That's no good. You can't have that. It has to be free floating like you see here, and it cannot touch any part of the ventral wall. If you push too hard, sometimes we get a heavy hand, right? If you push too hard, you may cause that abdominal circumference to become elliptical and mimic an omphalocele, in which case ease up off the probe pressure. You shouldn't be pushing that hard on a fetus anyway. And if you're not sure if it's an omphalocele, ease up off the probe pressure. If you ease up and you still see what looks like contents coming into the base of the umbilical cord, there's your answer. Here's a great example showing that you must include the fat. So look at all the fat around this fetus. Maybe mom's a diabetic. Maybe it's just a big kid like this guy here. But you have to include that fat. I will tell you, when you get to the 3rd trimester, this posterior border can be very hard to see. So just try and use what we say a gestalt, right? Just kind of a scientific wild guess to where your calipers are going. The good news is in the 3rd trimester, we're plus or minus 3 weeks anyway. So if you're a little off, you're not going to change the standard deviation by that much. And then here's another example showing the correct landmarks: spine, adrenal gland, stomach, hockey stick, and yeah, and yes, normally we get an ellipse, but just showing you where you would put the calipers. This is really important, the abdominal circumference for estimated fetal weight and delivery management. The long bones, you only want to include the shaft, the diaphysis of the long bone. You do not want to include that distal femoral epiphysis, so you only include the shaft. And so here again on the femur, just the shaft, not any of that cartilage stuff that's on the end. Here's the humerus. You're going to measure that the same way. The humerus is not a required part of a standard or of a standard growth ultrasound. We frequently look at it just to, first of all, you should be looking at the hands, the feet, and everything, making sure all the bones are there. But in addition, we don't necessarily use it as part of growth, but we do look at the humerus to just make sure it's normal. But we don't do it every time the patient comes in. The radius and ulna, tibia, and fibula, again, are part of a detailed scan, or if you suspect any kind of limb abnormalities. The ulna extends past the radius proximally, and then we count fingers and toes. The tibia is more medial and usually thicker than the fibula. And as the good doctor mentioned, again, we do always look at the angle of the feet and to look for rocker bottom. Common measurement errors. In the BPD, I already mentioned this, mistaking the peduncles or columns of fornix for the cavum septum and being at an oblique angle. The head circumference, some people keep that outer to inner and just open up the ellipse. That's incorrect. The abdominal circumference, not including the fat. And then in the femur, one measurement error that's kind of common is measuring the humerus instead of the femur. So my tip is, if you want to know if it's the humerus or not, start at the head, and the first long bone you see right below the head is probably a humerus. Then keep going, walk up the fetus, keep walking, keep walking. When you get to the urinary bladder, keep going inferior. The next bone you see is probably a femur. So the femur comes off the pelvis. To measure estimated fetal weight, which is very important for growth, there are several charts available. The head and the abdomen and the femur, to make up the estimated fetal weight, has about 15% error, plus or minus 2 standard deviations. And this hasn't changed in 30 years. It is less accurate in mothers with diabetes and in very small fetuses. The typical growth of a fetus is about 220 grams per week between 30 and 40 weeks. Now, keep in mind, ultrasound, as I mentioned, the further along you get, the less reliable we are. By the time we get to the 3rd trimester, we're plus or minus 450 to 500 grams. So anytime a baby is born and the weight is off by, even more than a pound, it's not terribly surprising, especially if they're post-dates or something like that. So here is one chart from the RUMAC textbook for manually calculating estimated fetal weight. What measurements do you have, and then which ones should you use? Generally speaking, all of us are probably using equipment that does all this automatically. Back in my day, that wasn't the case, and we had to do all these calculations by hand. Here is another chart for estimated fetal weight and the 10th, 50th, and 90th percentiles. Now let's introduce, fetal growth restriction. Fetal growth restriction, or IUGR, intrauterine growth restriction, and ACOG prefers FGR, but if you say IUGR, that's fine, is traditionally defined as a fetal weight of less than 10%. The one lab that I worked for insisted that FGR was less than 5%, but as soon as the fetus hit less than 10%, which was small for gestational age, or SGA, they would start monitoring with AFI and Doppler. So once, but the true definition of FGR and SGA are both defined as EFW less than 10%. Again, just some labs may not call it FGR until it's either less than 5% or the Dopplers are abnormal. SGA has the same definition as FGR, but here's the difference. SGA is usually constitutional, maybe mom's small, right? Mom and dad are small. So there's no pathology or pathologic issues causing SGA. It's usually constitutional. FGR, however, has a higher perinatal mortality and is usually from some cause. How do we make the diagnosis? Generally, it's made with EFW, but we also look at the HC to AC, and we'll talk about early and late FGR, umbilical artery Doppler, and fluid checks. So as I mentioned, FGR and SGA have the same definition, but the FGR fetus is more at risk for adverse outcome, which includes stillbirth and increased perinatal mortality. If the EFW is less than the 3rd percentile, the risk is even higher. The EFW and the umbilical artery Doppler are what we use to diagnose FGR. None of the other testing, and I'll tell you what all the other testing is, but none of it has the positive predictive value of EFW and umbilical artery. They may be used as an adjunct to EFW and umbilical artery Doppler, but at least in the US, they're not considered to be routine measurements done by all labs. So what are the other Doppler markers? The middle cerebral artery, the ductus venosus, and of course the biophysical profile is routinely done when a fetus is diagnosed with FGR, along with the non-stress tests, or CTG. The two types of FGR are early FGR, which is also known as symmetric, and late FGR, which is also known as asymmetric. The symmetric type, which tends to be more severe, and we'll talk about why, occurs in less than 1/3 of the cases of fetal growth restriction and usually occurs before 32 weeks. The reason why it occurs so-called early is because it's more likely to be associated with aneuploidy or other congenital anomalies. Aneuploidy, most commonly trisomy 18 and 21, anomalies like open neural tube defects and others, intrauterine infection, multiple gestations. If mom had a previous history of FGR, again, maybe she's got a bad uterus, which gives her a bad placenta, although that's usually late FGR. And it can be idiopathic. Maybe it's just a small kid, but again, if the Dopplers are abnormal, that's concerning that it's pathologic and not SGA. With early FGR, the head circumference to abdominal circumference ratio is normal. That's why it's called symmetric. Why? Because everything's small. And there may be oligohydramnios with early FGR, and there may be an abnormally calcified placenta. The only thing consistently predictive of outcomes is the umbilical artery Doppler. And I have a Doppler talk that hopefully you can come to tomorrow, and I'm going to go into all the details on what the Doppler looks like. For symmetric or early FGR, again, the baby is small because there's a reduction in not only the cell number, but cell size from some early insult. So all body parts are affected equally, everything's small. And if the baby has abnormal Dopplers, if the umbilical artery Doppler is markedly elevated, it is very predictive of hypoxemia and acidosis at birth. Late FGR, which by far is the most common type of FGR, and usually only occurs in the last 8 to 10 weeks of pregnancy, and is most commonly due from placental insufficiency. Remember what I said, if the placenta is bad, the baby's going to be bad, meaning it's not getting enough oxygen. You need that placenta to exchange oxygen and waste in order to have a healthy baby. So this is commonly associated with hypertensive disorders of pregnancy. And in this case, you're going to have an HC to AC that is discordant. The AC is usually more than 2 weeks behind the head circumference. Because it happens later, the baby's system is able to spare the head. We call it head sparing or brain sparing. The body knows, and there's changes in the heart that cause this, but the body knows that the brain must be preserved at all costs and shunts or diverts blood to the fetal brain, which causes a drop in the resistance of the middle cerebral artery. Again, the umbilical artery is what's predictive of placental resistance. Look at that umbilical artery and the SD ratios and PI of the umbilical artery. That will tell you what the placenta is doing. The small size of the abdomen is due to a smaller liver because of the decreased nutrition. And again, that blood is diverted to the cerebral perfusion due to changes that occur within the heart. So a whole cascade of things happens that causes this to occur. Late FGR still is associated with adverse perinatal outcome. It's not just, oh, well, it's late FGR, there's nothing we need to do. But it's usually, the adverse outcome is usually milder than with early FGR because it comes from a different pathophysiology. Although ACOG does not recommend this, ISUOG does recommend middle cerebral artery pulsatility index and umbilical artery pulsatility index ratios, which will give you the cerebroplacental ratio for late FGR. Again, this is not commonly done in the US, or if it's done, it's under research protocol, but it is in the ISUOG guidelines. So what do we have to do? First, we have to identify the small fetus. Then try to find a cause for the small fetus, and then management, which is usually monitoring to see if it is indeed SGA or FGR, and time delivery as a result. When we do the anatomy scan on a fetus that's suspected FGR, so let's say that 20-week scan, you suspect FGR, maybe you have first trimester dates, so you know the dates are good. You need to figure out, are there structural anomalies? We've had patients where they come in with a normal 14-week scan, and at 20 weeks, they're measuring 18. All my alarm bells go off when that happens. So are there structural anomalies? Is there a heart defect? Check the shape of the head and the limbs to look for some defect there. Is the amniotic fluid subjectively normal or abnormal? If it's abnormal, you may need to actually measure an AFI, although we don't usually do that until later in pregnancy. What are the differential diagnoses from FGR? Well, one of them is SGA, right? Just a constitutionally small fetus. You're going to do a umbilical artery Doppler and check the fluid. Or inaccurate dating. If mom didn't have a first trimester scan, if this is the first scan and she's 2 weeks off from her LMP or greater, you need to get another scan in 3 weeks. But of course, look for anomalies on the scan that you're doing. Fetal biometry, the abdominal circumference alone of less than 10% has a high sensitivity but lower positive predictive value than the EFW. Again, the EFW is the key parameter. The head circumference to abdominal circumference ratio, again, this applies to late FGR, should be greater than 1 at less than 32 weeks, 1 32 to 34 weeks, and less than 1 for greater than 34 weeks. The head circumference to abdominal circumference ratio is increased in asymmetric or late FGR and normal in early FGR. But again, the sensitivity and positive predictive value for HC to AC is not as good as abdominal circumference or estimated fetal weight. And one of the reasons, another thing that can throw you off, is if the fetus has an omphalocele or a diaphragmatic hernia where organs are not in the abdomen, that abdominal circumference is going to be artificially small. The fetal size alone does not make the diagnosis unless it's less than the 3rd percentile. So if you have an EFW less than the 3rd percentile, you can say it's FGR. Otherwise, absent of that, you have to have either abnormal umbilical artery Doppler or a decrease in fetal growth of greater than 2 quartiles or greater than 50 percentiles. In other words, if the fetus went from the 70th percentile to the 20th percentile, that's a concern for FGR. And again, that uteroplacental and fetoplacental blood flow may help distinguish FGR from SGA, at least in the ISUOG guidelines. But the key thing is multiple assessment tools are needed. In the 3rd trimester, you're going to want to do non-stress tests and biophysical profiles along with the Doppler. ISUOG on their guidelines from, I forget if this is 2019, I think it's 2019, has a diagnosis for early onset FGR, and then there's some guidelines to follow, and then what are you going to do about it? And here's the surveillance that's recommended, and I'll talk more about this momentarily. So what are some of the maternal causes of FGR? Maternal hypertension, pregestational diabetes, autoimmune diseases, any cardiovascular or lung disease, tobacco and substance abuse, malnutrition, multiple gestation. Healthy mom, better chance for healthy baby. Lab testing that is recommended for fetal growth restriction. Again, we talked about the torch, cytomegalovirus. Look for a decreased head circumference. The one legal case I told you about where we had, oh, actually, I didn't tell you about it, but we had one of the legal cases I reviewed was a baby that, no, I did mention it, the twins. Yeah, the twins with CMV. They both had decreased head circumference. The one that died had a markedly decreased head circumference. It was never picked up by the interpreting physician. So again, if they have CMV, it may require amniocentesis, but there's no treatment. You may want to do a maternal serum HCG, because if it's elevated in the second trimester, it could be placental insufficiency. Same thing with the alpha fetoprotein. Fetal causes of fetal growth restriction, exposure to teratogens, again, fetal infection from maternal infection, aneuploidy, and congenital anomalies. So skeletal dysplasias are another reason to have a small baby. Placental causes, primary placental disease, placental abruption or infarct, placenta previa, and placental mosaicism. ACOG recommendations are serial growth ultrasounds at 3 to 4 week intervals. You do not want to do them every 2 weeks. You're going to have false positives and upset patients if you do them too soon. So no sooner than 3 weeks. If it's a real suspected case of FGR, like we're very concerned, we'll do it at 3 weeks. If we're only mildly concerned or we think it's SGA, we'll do it at 4 weeks. The umbilical artery Doppler near the fetal abdomen. There are some who say mid-cord, and that's fine. If you get it mid-cord, it's easier to get mid-cord. But having said that, the resistance does change, and I'll talk about that in my Doppler talk. The resistance does change depending on where you measure, but you need to get an SD ratio and a pulsatility index. SD ratio is systolic to diastolic. Middle cerebral artery Doppler has not been shown to improve outcomes, but other societies do recommend it. Like I said, the cerebroplacental ratio is recommended by ISUOG, but it's not consistently reliable, as they mention in their guidelines, and has a low positive predictive value. The main clinical characteristics, this is from the ISUOG practice guidelines, the main clinical characteristics of early and late onset fetal growth restriction. I am not going to read this to you. It is in the guidelines that are available to you online. And then the definitions of early and late onset fetal growth restrictions. So again, we talked about these in my talk, but I just wanted to show you the chart from their guidelines. So there's no effective treatment for FGR. So what do you do when you say, congratulations, you have FGR? What do we do about it? Well, nothing. I mean, we put people on bed rest. We don't actually know if that does anything. If they have hypertension or preeclampsia, well, we can treat that. So mag sulfate or whatever the indications are to fix their hypertension or preeclampsia, we can do something about. If it's an aneuploidy, there's not much we can do about that, short of termination or just preparing the patient for delivery. If there's isolated FGR, they can recommend delivery between 38 and less than 40 weeks. And if there's other confounding factors, they recommend delivery between 32 and 37 and 6-7 weeks. They don't indicate C-section just for isolated FGR. If there were other issues, then like congenital anomalies, it might be indicated. And plan a delivery in a tertiary care unit. This is really important, where there's a neonatologist and an intensive care nursery, because you're probably going to have a really sick baby at birth. Here's another chart that I found, and this is also from ISUOG, and this is the Doppler and cardiotachography, we call it NST, examination in the FGR fetus. And what I like about this chart, it shows after 36 weeks, just the liver, right? I mean, or especially if the umbilical artery is high. deliver. And I'm not even going to get into steroid use. You can do your own research on that, about giving steroids in the presence of FGR. That's outside the scope of this talk, but that's something you can look into as well. And then for each gestational age with umbilical arteries being abnormal or the ductus venosus being abnormal, there's different recommendations for when to deliver. The SGA fetus. So the fetus is between the 5th and 10th percentile, but it's still growing. Every scan, it's growing appropriately. It's small, but it's growing. And it has a normal AFI, and the Doppler and the bios are all normal. These patients still may have adverse outcomes, but much, much, much less than with an FGR fetus. And so you want to just monitor them. Again, if they're constitutionally small, they're going to be fine at birth. They're just going to be small. But we still do AFI Doppler biophysical profiles and fetal weights every 3 to 4 weeks, just to make sure it's SGA. They don't usually have any problems at birth unless these parameters start becoming abnormal. And I would be remiss if I didn't mention the LGA fetus, because they can also have adverse outcomes, but for different reasons. The definition of LGA, large for gestational age, is greater than the 90th percentile. And the definition of macrosomia as its own pathologic condition is an estimated weight greater than 4,000 grams in a non-diabetic mother and 4,500 grams in a diabetic mother. There can be risks for perinatal morbidity and especially delivery issues. Risk factors: maternal obesity, previous LGA, post-dates pregnancy, excessive pregnancy weight gain, multiparity, and AMA. Diabetic mothers tend to have excess maternal glucose, which causes the baby to produce more insulin, which causes the baby to get large. The problem with delivery is shoulder dystocia, which may occur up to 31% of the time compared to 3 to 10% in a normal size fetus. Other risk factors are fractures, meconium aspiration, and neonatal hypoglycemia. 10% of births are LGA. 8 to 10% are greater than 4,000 grams, and 2% are greater than 4,500 grams. Measuring the abdomen with an LGA fetus. This is a properly measured LGA fetus. Again, make sure you include that fat. Again, with diabetes, you're going to see this. This is an improperly measured abdominal circumference. You can see, this is a diabetic mom. You can see the skin comes out to here. Even if you're not sure back here, follow this plane, follow it down. This abdomen is grossly undermeasured, and I will tell you it led to an adverse outcome in this case. And I'm not even going to talk about the fact that there's no stomach and that this is not a hockey stick, it's approaching the ventral wall. This is an incorrectly measured abdomen. And then I just have another like cautionary tale. So this is a 27-week gestation with severe symmetric growth restriction. Here's the problem with early growth restriction. If you're not sure of the dates or you're not careful, you can miss this. So for example, you do the scan, 24 weeks, 24 weeks, 24 weeks, 24 weeks. Cool, everything's 24 weeks, it's normal. Well, wait a minute, what's the estimated due date? What's the gestational age? 27 weeks, oh. So if you're not careful, you may miss the fact, even though everything's symmetrical and it looks artificially normal, you have to look and see what the gestational age is, because this may be early growth restriction versus bad dates versus, you know, something else. So it's, don't assume that just because everything lines up that it's normal. You have to compare it to the gestational age and of course the EFW. So in this case, the EFW I think was less than 2% or something like that. I forget. Here it is. There it is, 2%. Yeah, so the EFW was in the 2nd percentile. That's abnormal. And yeah, so here you can see everything's small. I only say that, this is not a case that I had, this is from the internet, but I will say I've had cases like this. Okay. And then the last thing I want to mention, I'm somebody who teaches physics. Physics is my specialty. And so I always like to throw in a thing on bioeffects. The potential benefit of ultrasound, which is huge, must be weighed against the theoretical risk of bioeffects, which are changes to the tissue. And we recommend the ALARA approach, as low as reasonably achievable. In short, decrease your dwell time, especially when scanning the fetal head. Don't stay parked on the head any longer you have to. And don't do Doppler just for fun, but all that gets thrown out the window when you have pathology, because then the benefit of performing the exam outweighs the theoretical risk. So everything goes out the door. Like if you have a first trimester and it's abnormal, do all the Doppler you want. It doesn't matter. And a healthy baby, minimize Doppler, minimize scanning around the head unless you need to. And then on your machine, every ultrasound machine gives a thermal index. If it's less than or equal to 10 weeks, this should be the TIS. And if it's greater than 10 weeks, it should be the TIB, thermal index for soft tissue, thermal index for bone. Your applications person should make sure the machine is set up like that. And in the first trimester, if there's no reason to do Doppler, although I think Dr. Simon gave us several convincing reasons to do Doppler routinely in the first trimester. But if all you're doing is a happy, healthy baby, 6 weeks, and you just want to document heart motion, use M mode instead of Doppler. And that's all I have. And I thank you very much for your time this evening, I'll say, and I'm happy to answer any questions. Okay, we have one question.
Thank you, Dr. Tracy.
Thank you. It says if a patient comes to me for the first time at 22 weeks and there's a difference of more than 3 weeks, should I correct the LMP or label as FGR? You can't, if you don't have, so first of all, ask the patient how good are her dates. Some patients will tell you, I'm very irregular, in which case the dates are not reliable. And I would lean more towards, let's look at things, see what things look like, and then come back in 3 weeks. If the patient has good dates, she says, nope, every 14 days like clockwork, I have my period, I know I ovulate, you know I have good dates, or I only had intercourse once in the last year, and so I know that this is when, conception probably occurred, right? So if it depends on whether the dates are reliable or not. If you have reliable dates, this 3 weeks would greatly concern me. I don't know that I'd slap a label as FGR. I would slap a label of suspected FGR, and I'd bring her back in 3 weeks. If she has really, really good dates, you might consider correcting the LMP, but you're still bringing her back in 3 weeks because you have to be sure. And, when you're scanning, look for other signs too, right? Look at the placenta, check the fluid subjectively. If her dates are terrible, you may be inclined to redate her, but you're still bringing her back in 3 weeks to see if the growth curve stays stable. So, is she 3 weeks further along now? Or is she 2 weeks further along now, or 1 week further along? Because we've had that before, where we bring a patient back in 3 weeks and the baby's grown 1 week. This is a markedly abnormal fetus. What should the minimal interval between growth scans and Doppler studies? So the recommendations may vary between ACOG and ISUOG. We do 3 weeks for growth scans and no sooner. We will not do a growth scan sooner than 3 weeks because of the standard deviation. Especially in the third trimester, it's plus or minus 3 weeks. There's literally, like, you may find a baby, a normal fetus that shrinks if you do it every 2 weeks because of the standard deviation and the rate of error in ultrasound measurements in the third trimester. So no sooner than 3 weeks, that's your minimum interval. For Doppler studies on a suspected FGR or proven FGR case, we will do weekly, at a minimum, weekly Doppler AFI, and then once they get to third trimester, usually 30, 32 weeks, they'll do non-stress tests, sometimes sooner if it's a really sick baby, because they may need to deliver sooner. But in one article that I read, the biophysical profile does not become abnormal until right before fetal death. So, the non-stress tests are important. The Doppler studies are important. We've had patients with severe growth restriction that get twice weekly Doppler and AFI and NSTs. Irregular menses presents at 20 weeks, but ultrasound, it's 14 weeks. So if it's a regular menses, I'm ignoring the LMP. At a 14-week scan, I'm bringing her back at 17 weeks and checking the growth. And I mean, technically at that age, you could bring her back at 16 weeks and check the growth, but I have a feeling they'd still say come back at 17. You could do an early anatomy scan at that time. No, it's not. You still have to bring them back at 20, 21 weeks for an anatomy scan, but at 17 weeks, you might be able to do a very early anatomy scan. So I'd say at the earliest 16 weeks, but I'd probably bring them back at 17. But, again, I'm not an obstetrician, but that's what I think they would do. You're all asking excellent questions, and I thank you for that. Keeping me on my toes.
I think that's. Yeah, I think we should conclude here. There's no more question.
Okay, wonderful. Well, thank you all, and I look forward to seeing you all
Thank
tomorrow.
you very much. It was very nice
Okay.
lectures. Both of your lectures very nice. Thank you. Thank you all the delegates. And we'll also share the recording of today's session, which is valid for 3 days. So tomorrow morning, we will send it to you all. If you miss anything, any session, you can review it again. Thank you again, Dr. Tracy. Thank you.
Okay, thank you. Have a good one.
Good luck. Bye-bye.